Good evening, all respected faculties. I invite you all for the Core Connect live show on PCOS Newer Insights on behalf of IFS Chhattisgarh with Special Interest Group PCOS. MOC for the today's event is Dr. Shweta Sablani. Dr. Shweta Sablani is Director and Consultant of IVF and IVF Specialist at Swastik Hospital, Bilaspur, Chhattisgarh. She is certified with IVF training and ultrasound in pregnancy by Omega Hospital, Nagpur. Ma'am, over to you for further proceeding. Dr. Shweta Sablani is director.
Can hear the two simultaneously. What is happening? I don't understand.
Ma'am, now it is clear, ma'am.
Yeah, clear now. Okay. Thank you, Abhishek. A warm good evening to all dear friends, our guests, and all the participants of the session. As we all know, we are here live web on PCOS Newer Insights. Again, welcome to all. Now I invite Dr. Prakriti Verma Madam to give us a note. Madam is Director, Vardhan ICSI Center, Consultant at Care and Cure Super Speciality Hospital, Bilaspur. Madam will give us a thanks note, a welcome note. Dr. Prakriti Verma Madam.
Yeah, very warm welcome to all of you. Good evening, everyone.
Good evening, everyone.
On the behalf of Indian Fertility Society, I just welcome to all the faculties and I want to welcome our SIG PCOS group and to give Dr. Bharti Dhore Patil Madam, who has given us opportunity to associate with them. And because today's topic is PCOS and it is very vast topic and we cannot cover it in 2.5 hours or so. Now today we have just taken some recent topics related to PCOS. So I just hope that it will be beneficial for all of us. And again, I want to welcome all faculties, and it is very beneficial for all the gynecologists and even infertility specialists. So thank you so much for this webinar. And now I over to Dr. Shweta for proceedings.
Thank you, ma'am. Now moving to our first session, that is endometrial function in PCOS. Our first speaker is Dr. Venugopal Menon sir, and I invite our chairperson, Dr. Sushma Verma madam, to introduce our speaker. Dr. Sushma ma'am.
Thank you, Dr. Thank you, Dr. Shweta.
Lines for you.
This fact is well known that the endocrinologic and metabolic abnormalities in PCOS may have very complex effects on endometrium, leading to infertility and the endometrial disorders. And to know more about it, I would like to invite Dr. Menon, Dr. Venugopal Menon, for his lecture on endometrial function in PCOS. Dr. Venugopal, introduction, he is a well-known figure in the field of infertility all over the India. But I am introducing him in very short. He is the consultant ART specialist at ARMC IVF Fertility Center, Thrissur, Kerala. He is the Secretary General of Federation of Obs and Gynae, Kerala, Secretary Kerala IFS chapter, and convener endocrinology of SIG IFS. So now over to you, Dr. Venugopal. We are lucky to have you in this webinar. I have heard you in IFS conference at Hyderabad.
Oh, thank you, madam.
Good evening, Dr. Venugopal sir. Good evening.
Yeah. Am I audible? Am I audible? Yeah.
Yes, sir. You are audible and slides are visible, sir.
Slide is visible. Yes. So first, very good evening to all of you. I want to start by telling a big thank you to the SIG PCOS Bharti Dhore Patil madam. Thank you so much, and also to the Chhattisgarh chapter for giving me this opportunity to speak in this very prestigious symposium on PCOS. Thank you very much, and I'm very happy to be amongst all of you. So the topic given is endometrial function in PCOS. Now, when you see in PCOS, many a times we are talking a lot about, ovulation induction. We are talking about the outcomes of PCOS, but very little discussion about endometrial function in PCOS. And many times in journals like Human Reproduction, Fertility, Sterility, you find articles regarding endometrial function. But as clinicians, the moment we see these articles full of genetic upregulation and downregulation, we would rather let it pass and say, okay, there may be some effects and let us see. And that sort of approach is what we have. And same approach even I carried when, I was trying to make a presentation here. I saw a very good article in Human Reproduction Update, HR Update recently. Then I thought if I present this article like that, then people will go to sleep. So, let's make things a little bit more simplified and practically useful to all those who are listening. So I just, this introduction regarding PCOS is very relevant because when we talk about PCOS and how the endometrium is affected, it is these main features that affect the endometrium. One is the hyperandrogenism. The other is prolonged oligo or anovulation. Prolonged anovulation, what effects it has on the endometrium. And this polycystic ovarian morphology and our recent raised AMH levels, raised antral follicle levels. We know what it does to the oocyte, but it's not so clear as to what it does to the endometrium. Why that happens is because there are many confounding variables. Confounding variables means, when there is poor outcome in PCOS, it could be because of endometrium, it could be because of oocyte quality, it could be even because of embryo aneuploidy. So this is the confusion. So it's very difficult to take out this particular thing and say that this problem happened because of the problems in the endometrium. So, we know this, that, again, this is well known to all of us, that, different phenotypes of PCOS are there. Some of them are severe phenotypes, where there's hyperandrogenism with ovulatory dysfunction, with PCOS, then it becomes a severe type. Different types of severity is there of PCOS. So here, pronounced menstrual dysfunction is seen usually in phenotype A and B. Other menstrual dysfunction may or not be there in the other phenotypes, but as endometrial function, if you're looking only for menstrual dysfunction, it is more pronounced in phenotype A and B. Now, in the course of my talk, we will just try to answer these three basic simple questions. First question is, how are the clinical features of PCOS? That is, how is hyperandrogenism? How does it matter? What difference does it make? How does hyperinsulinemia, what difference it makes to the endometrium? Second is, we have to answer this question, is the endometrial, is it really altered, or is it we are imagining that something is happening to endometrium? And the third one is that if something is really happening to the endometrium in PCOS, then what interventions we can do and how they will help us to improve the endometrial function. These we'll just try, these three simple things we will try and address. So in that pursuit of that, we will go ahead one by one. That we will go to think that when we are talking about endometrium, when we are talking about PCOS, what really matters is the receptivity. No, everybody will agree that it is a receptivity. What receptivity we are talking is that receptivity failure. When we say endometrium is affected, that means it has become less receptive. So complete receptivity failure will present as infertility or recurrent pregnancy loss. But even if there is modest receptivity failure, it could have, abnormal embryo implantation causing different complications, gestational hypertension, preeclampsia. We all know this particular slide that, endometrium has to be affected. That is why you see that PCO has adverse pregnancy outcomes, 3 to 4 times increased risk of PIH and preeclampsia, premature delivery, our fertility related issues, and 3 to 5-fold increase of endometrial cancer. How that happens, which is the feature that is more dangerous, and which clinical features and their effect on the endometrium is what we need to know. Now here we have to understand that hyperandrogenism, when we talk about, is there in most of the phenotypes of PCOS and one of the standout features of PCOS. So endometrium in PCOS patients has preponderance of estrogen and androgen action and compromised progesterone action. So hyperandrogenism can compromise endometrial function either directly or in combination with hyperinsulinemia. You will see that many of these features of PCOS, they act directly or with hyperinsulinemia together. See, high serum testosterone decreases expression of endometrial receptivity genes. It has been proved. There is no dispute about it. That is why, when serum testosterone is high, many times, even when we are doing scan, we will find thin endometrium and there will be decreased expression of endometrial receptivity genes. Along with insulin, it produces mitochondrial dysfunction. This is very important for energy, mechanism of the endometrium. And also endovascular trophoblastic invasion is lower in patients with PCOS. That's why we get these features like your hypertension and all this. So hyperandrogenism is definitely detrimental to the endometrium. And as you can see here, that it can cause impaired endometrial receptivity, and in combination with the other features affect corpus luteal function. It can induce endometrial hyperplasia. So a lot of, this hyperandrogenism causes a lot of problems. What about chronic anovulation? What does chronic anovulation do? It decreases the available progesterone. That all of us know. And there is minimally regulated estrogen activity. Now, progesterone is playing a central role in what? Neovascularization to support embryo implantation. All of us know progesterone is the hormone of pregnancy. If it is not there, then what would happen? We would have abortions, we would have implantation failures. Similarly, progesterone restricts androgen receptor expression, So hence, once the progesterone is less, there will be more androgen receptors that are expressed. So again, that's another problem. So that is how anovulation. We saw that earlier slide, we were talking about hyperandrogenism. Now we are talking about chronic anovulation. You will see that many of these areas, there is a small overlap. Now, this is a basic which all of us should know, that what happens in PCOS, that there is estrogen receptor overexpression, oversensitivity. So overactivity of estrogen, maldistribution and dysfunction of progesterone, and overexpression of androgen receptors. So overall, the environment of the endometrium is disturbed, and that disturbance gives rise to different. Now we see lot of antral follicle count, high AMH. We wonder, AMH, does it have any direct effect? See, it has pro-apoptotic effects. Pro-apoptotic means apoptosis is programmed cell death. So there will be premature programmed cell death. That will, affect the viability of the endometrial cells. So you can understand that, if the cells are programmed to die, definitely they will not function and there will be a problem. But AMH is not a predictor of implantation or clinical pregnancy. Okay. So PCOM, when you see a morphology of polycystic ovary, there will be high estrogen, high antral follicles, and that is how it will affect. Now, what about obesity? Now, obesity, does it have any effect on endometrium? Definitely obesity, because we saw that insulin resistance is a problem. Obesity will promote insulin resistance, hyperandrogenism, hyperinsulinemia, inflammation, all these things. Free fatty accumulation, acid accumulation is detrimental to the endometrium. There is no way that it is good for the endometrium, and it impairs endometrial function even in women without PCOS. That is very important. So obesity, even if the lady does not have PCOS, that's a problem. What about hyperinsulinemia? We discussed that hyperinsulinemia can have its effects directly or in association with things like hyperandrogenism. So it acts by inflammatory pathways. Okay. So insulin resistance causes several alterations in insulin signaling and glucose transport in PCOS endometrium. Hyperinsulinemia causes aberrant gene expression. I do not deliberately mention all those genes because there are hundreds of genes that are there. But remember, hyperinsulinemia, it causes inflammation, and inflammation means a lot of cytokines are released. There are pro-inflammatory cytokines, they alter the normal path of insulin. See, once the normal path of insulin and that mechanism is disturbed, then there's a big problem, because there is, these reactive oxygen species, the increased production is there, decreased elimination. So, there's a very, very, very hostile environment that is there. Then it acts on mitochondria. All the energy mechanism goes for a toss. So, these are all friends. They work, hand in hand. Your insulin resistance, your inflammation, your hyperandrogenism, all of them are together. And together they wreak havoc. Where all they cause damage, DNA synthesis problems, mitochondrial metabolism problems, cell regulation and proliferation, increased apoptosis, cell transport is disturbed, cell signaling, all these things are disturbed. So overall, you have to understand it's sort of, depending upon the phenotypes. That's why I showed the slide of the phenotypes in the beginning. Different phenotypes, this problem, the magnitude of the problems is different. The more the severe the phenotype, the more the problems are going to be. They all act in conjunction. Look at this. The AMH is going to directly cause endometrial dysfunction. PCO morphology is going to increase estrogen, then cause hormone aberration and cause dysfunction. So all of them together And imagine the severest phenotype where there's hyperandrogenism, obesity, PCOM, and increased AMH. What must be happening to the endometrium? Definitely going to cause endometrial dysfunction altogether. So that's very significant. And clinically, then how these people present in different phases of life, they present differently. See, in an adolescent girl, it may be just your hair loss, this thing. Menstrual irregularity is a reflection of endometrial affection. In reproductive period, you have this infertility, pregnancy loss. Then you have during pregnancy your PIH and the gestational diabetes. And in menopausal, perimenopausal, you have this metabolic syndrome and the carcinoma endometrium. All expressions that, of all this gives us a thought process. Yeah, we feel that the endometrium is being affected in PCOS. Then those who are critics, they like to ask always that, how are you sure that there are not other culprits? Could it be that, why do you want to think, doctor, that it's only the endometrium that's going to be affected? Why could not it be a problem with the egg? So why you are not thinking like that? Why you are blaming this endometrium alone? So let's see obesity and insulin resistance. Very good studies which show that hyperinsulinemic, insulin-resistant PCOS women, when compared to normal insulin PCOS women, significantly implantation, clinical pregnancy, and ongoing pregnancy rates, even after controlling for age, BMI, and lipid profiles. Even after controlling for age, BMI, and lipid profiles. So, it's not just about your insulin resistance, your BMI that matters. Even if you control for all of those, still the outcomes are bad. Then some people will say that why not you think that PCO patients have more aneuploidy, and maybe because of aneuploidy there's this very good prospective cohort study. Spontaneous first trimester miscarriages demonstrated lower aneuploidy rates in patients from PCOS with the complete phenotype in comparison with non-PCOS. So that's another lesson to learn. After controlling for maternal age, abortus of PCOS, there are lower aneuploidies. So again, you will think, okay, maybe the endometrium is the culprit. And some will say, the egg quality is always very poor in PCOS. That is the reason for all this. Again, now with our donor oocyte program, we see that the donor oocyte patients who have PCOS, they get plenty of eggs. And when we transfer them, you get pregnancy. There is no problem. So why you get so that egg is not the problem. It is the endometrium which is the problem again here. If you transfer. So this is another lesson that we learn from the donor oocyte model. It's the most compelling evidence that something may be going wrong with the endometrium. So we agree that the different features and clinical features of PCOS, they do affect the endometrium. And that is independent of your oocyte quality, that is independent of your other things, variables like aneuploidy and all this. So once a practical question that what can be done then if you think that PCOS affects the endometrium, then what should we do and how do our our interventions help? Because naturally prevention is always better than cure. So if we are able to do something to prevent this effect on the endometrium, it will be good. Now, the first thing that comes into mind is lifestyle modification. We tell all patients with PCOS that you modify lifestyle. Does it have, it definitely has an effect on PCOS, but does it have an effect on the endometrium? You should understand that whatever, there is no direct effect of lifestyle changes on the endometrium, but whatever is there is because the patient will lose weight. So if her obesity decreases, naturally by the mechanisms I said, similarly if her hyperandrogenism decreases, then it will help. And the most beneficial intervention found in the effect on endometrium is to decrease and cause a hypocaloric diet, decrease in fats, because like I said, free fatty acid accumulation causes havoc in the endometrium. So these are well-researched studies. Now, metformin is one medicine which all of us like to write, and then lot of studies which show that metformin is beneficial with, in different things. Menstrual frequency becomes better, ovulation becomes better. There are a lot of gene studies which said that, it's better, but you must know that, the very systematic reviews do not support the clinical effectiveness of metformin on reproductive outcomes and specifically on the risk of miscarriage. So that's why, probably we are moving away from metformin and trying other alternatives to metformin, because even though studies show that the gene profile and all is changed, but in practicality on the endometrium and in terms of outcomes, like, decreasing risk of miscarriage does not seem to have much of an effect. Now, something we all like to do in PCOS patients is to do withdrawal bleeding. Chalo, let's do progesterone withdrawal. Let us do, OC pill induced withdrawal and see whether, endometrial quality improves and outcomes improve. Now, you have to remember that, we use it, progestin withdrawal bleeding associated with higher clinical pregnancy rates than placebo, okay, in an unselected infertile population. Oral contraceptives commonly used for scheduling the IVF cycles reduce live birth rates compared to progestin-induced withdrawal bleeding or spontaneous menses. And anovulatory patients who receive fertility drugs without progestin withdrawal bleeding to good effect. So you need not, it's not absolutely essential that you should cause shedding of the endometrium and that is going to change the profile of the endometrium. That is not really quite true. What about the use of ovulation induction agents? See, you have to remember that when you give, everybody knows now, the whole world knows that, letrozole compared to clomiphene citrate is slightly better in terms of all the things, in increasing endometrial receptivity, cell proliferation, all these things, embryo implantation and development. That's a known fact. But one must remember that there's no supportive use of these drugs in patients who are already ovulating. That means if a lady is already ovulating, there's no use of giving these drugs. And then also that effects of gonadotropins are also more physiological on the endometrium. So your ovulation induction agents probably, they help to some extent in overcoming the problem. What about bariatric surgery? We know that bariatric surgery by its benefits in decreasing obesity and will be useful to improve the endometrial function, but it's always to be the last option. Just because some studies show that bariatric surgery, is good for endometrial function, we should not start recruiting patients and doing bariatric surgery unless it is indicated. Now, some people like to give medicines like OCPs and, anti-androgens. You said that androgens is bad for the endometrium. So, see, OCPs as a pre-treatment, they have been found to be, beneficial in some patients and reduce the risk of pregnancy complications before ovulation induction with clomiphene. Some patients. But drugs like flutamide, they decrease androgens by different mechanisms, but they are teratogenic and they are always used with OCPs. So, you can't find out their independent effect on the endometrial function. Then some people like to say that we'll do an endometrial injury and see what happens, whether endometrial function will. See, it may induce an inflammatory reaction and modification of gene expression profile. But its benefit is, you can't do this for everybody. You can think about doing this with people with, the benefits are not proven, with repeated implantation failure, but not in an unselected population. In IUI and all that, it doesn't make much sense, just to improve endometrial function, you try and scratching. What about some other, probiotics? This is very much talked about now, very surprising. And some seems to be very promising. There's an accumulating, evidence that endometrial function actually might be influenced by the gut microbiota. That's very surprising, but probably very true. Modification of the endometrial fluid. Many times it has been proven now that that endometrial microbiome or microbiota, they influence reproductive outcome. And sometimes they say that there's a crosstalk between the gut, vaginal, endometrial microbiota, and so sometimes there's a lot of evidence which says that improving the gut microbiota may actually now play a role in PCOS pathogenesis, effect on the endometrium and all that. So we have to wait for that. What about other interventions? That laparoscopic ovarian drilling, it has been found to be helpful in some patients, but that again doesn't mean that we go on doing laparoscopy for everybody. Vitamin D supplementation is another intervention that has been shown to be of benefit in a small subset of patients, but not across the board in terms of endometrium, not in terms of PCOS, okay? Endometrial function, it's doubtful. Similarly, drugs like resveratrol, N-acetylcysteine, and coenzyme Q, not yet clear. So I think though the topic was a little bit overwhelming in terms of, trying to understand it, but I think that we have to look beyond the oocyte quality and we have to look, we think about stimulation, egg quality when we think about lifestyle and interventions. We don't think so much about the endometrium, when many a times it's the endometrium in PCOS which gives us the problem. So there is overwhelming evidence that that endometrial factor is there, which influences outcome in PCOS. Of course, like I said, because of this confounding variables, it's difficult to pinpoint features on the endometrium. So we need new approaches to confirm that, this particular thought process. And we need to understand that there are some interventions which can improve the endometrial dysfunction in affected women, but more evidence is needed in this regard. So I will just stop at that, and I thank you for a patient hearing. I must admit that it was a very theoretical topic, but there's not much I could have done in terms of adding humor or spice to it. So thank you very much, and I hope that it was worth listening for the few moments. Thank you very much.
Thank you, Dr. Menon. It was a wonderful summarization of PCOS and its complications and what actually works. What I conclude is that you are not in a big favor of OCPs and metformin. OCPs and metformin.
See, metformin came, and see, metformin is now not universally prescribed. Not that I'm not in big favor, but I pick and choose my patients whom I would like to prefer metformin in PCOS. See, from what I I always thought, the thought process is, what actually is the central pathophysiology is insulin resistance. What it means is that, for the glucose to enter the cells, you need insulin mediated mechanisms. When there's insulin resistance, that doesn't work. Okay. So you have to identify patients who have insulin resistance, an abnormal glucose tolerance test or some surrogate marker of insulin resistance, like say acanthosis, which will tell you that, this is the patient who's going to benefit from metformin. So you have to choose your patient. Similarly, if you are inducing ovulation and you find that it doesn't respond to regular clomiphene and medicines like that, that may be another case where you may add metformin. Similarly, it's been shown that metformin prevents hyperstimulation when stimulated for IVF. So you be selective in using metformin. So that's my thought. Then OCPs I do use in PCOS when I find very high levels of luteinizing hormone. Sometimes, for those patients I may use OCPs, but not a regularly very big fan of OCPs. So that's my thought on it. I think Bharti madam may be able to add a little bit more about these two.
So you made it very clear that there's so much preponderance of estrogen and the comparative deficit of progesterone, which is worsening the endometrial function, and gut microbiotas and these drugs are probably going to benefit us a lot. Thank you very much, sir.
Lot of papers regarding this gut microbiota and those sort of things. The new directions in PCOS, because I think this is one area where the research is never ending, sort of, because of the different phenotypes and this thing. So, yeah.
Thank you, Dr. Menon. It was wonderful listening to you.
Yeah, Venu, it was excellent. I had one question. Very nice presentation. And of course, everybody wanted something, some humor, something new will come out. when Prakriti asked me what different things we are going to do in this PCO CME webinar, I said the topics would be very different, challenging to the speakers, faculties. Otherwise, same thing we listen. What happens when you have a different topic, it stimulates your mind, like looking at that. So it was wonderful, but very nice. I just had one question to you.
Yes,
the PCO patient, you see a different kinds of endometrial thickness and the pattern.
Yes, ma'am.
Thickness is one and pattern is another thing. So how that all you decide your patients depending on the pattern and how will you rectify them? So like suppose a patient who is a hypoestrogenic.
Yes, ma'am.
That patient, your stimulation will be different because you will get thin endometrium if you give a letrozole tablet. So do you see the endometrial pattern in the beginning, like day 2 or day 3 of the cycle, and maybe day 5 days? This will be a practical thing for the, all people to take home, like in which PCO patient you will find a thin endometrium, which PCO patient will have a very hyperplastic endometrium, wherein their IUI results will not be there. So probably they will drop that cycle and maybe they will go for that triple line endometrium and like that.
Madam, mandatorily, I will always do a day 2 scan for all patients whom I'm starting my stimulation. That will definitely give us when you're starting itself with a thick endometrium, then that's a problem. Then as the stimulation goes on, then, as you assess the endometrium, many a times I find that the hyperandrogenic ones, they are later at day 8, day 9, they're really present with very thin sort of endometrium, and there you have to do a different sort of stimulation strategy for those kind of patients. You have to address the hyperandrogenism, because how much ever you try without correcting the hyperandrogenism in those patients, it's a problem. Whether thick endometrium, generally you like to, I generally like to give maybe a little bit of OCs or something, thin down the endometrium and then start the stimulation. I just keep things simple like this. Otherwise I'm not having any sort of specific strategy.
Thank you. Thank you.
This is I want to ask one question. Either Dr. Venugopal or Dr. Bharti ma'am can answer. Dr. Venugopal has said he first see for insulin resistance and then only he gives metformin. But ma'am, I have examined many patients with PCO. Their fasting insulins are in normal range and they are not having any other feature of insulin resistance. So in that patient, what you do in your practice, whether you are starting metformin to every patient of PCO or you are saying just hyperinsulinemia or insulin resistance in such patients?
See, I am not mentioning fasting insulin as such. What I'm doing is I'm doing a simple glucose challenge test and then seeing for impaired glucose tolerance and for surrogate markers of insulin resistance like your acanthosis and those sort of things. And that too in patients who, who don't develop follicles, who are stubborn to ovulation induction. Those are the patients where, I listen to this interesting concept that, for a follicle to grow from say 2 millimeters to 18 millimeters, it needs energy. Now that energy will come in the form of glucose. So if your insulin mechanisms, insulin resistance is there, your insulin mediated entry of glucose into the cells is a problem. That is why the follicle doesn't extend grow to 18 millimeters, because it doesn't have energy. Now, in those group of patients, where you want to facilitate, those are the ones where, I will think about starting this sort of sensitizers and getting that mechanism. All of us studied during our biochemistry, that you need, for the activation of the energy cycle, you need glucose. And glucose enters into the cell by this insulin-mediated mechanism. So, a stubborn follicle is some kind of indication that, there may be some kind of insulin resistance. That's my thought about it.
And what is your experience regarding myoinositol, D-chiroinositol in cases of endometrial abnormalities in PCOS?
See, all of them are insulin sensitizers. So I don't see previously also, if those who are practicing since some time, this myoinositol, chiroinositol is now there, but there was even, one preparation called hyponate, which was also having D-chiroinositol and used since time immemorial. And all these are insulin sensitizers. So wherever you feel that insulin resistance is the problem, I don't find problem with using either of these medicines. That's my thought. I think Madam could add on.
I think in my talk, we are going to discuss that all.
Okay, ma'am, it's fine.
Because that talk is only for insulin resistance and hyperandrogenemia.
Okay.
So we'll discuss that.
Okay, ma'am.
So just one more question, sir. Do you, these kind of patients who have hyperestrogenemia, do you... Hello?
Yes, you are audible.
My question was, if the patient is so hyperestrogenic and we want to do a frozen transfer in PCOS patient, so do you downregulate them and then give them estrogen and transfer?
In PCO patients?
Yeah, in the PCO patient. For the frozen transfer, do you downregulate?
I may or I may not. That's okay. Both of it has similar results. I am not so particular about downregulation in those patients.
Okay, so thank you, sir.
Thank you. Thank you so much, Dr. Venugopal sir, for enlightening the topic so nicely. Now for the second session, that is insulin resistance and hyperandrogenism linked or delinked in PCOS. I invite the speaker, Dr. Bharti Dore Patil ma'am, and our chairpersons, Dr. Monica Agrawal ma'am and Dr. Sangeeta Sinha ma'am. Dr. Sangeeta Sinha ma'am will invite our speaker. Madam is MBBS, DGO and PGA in ART. And Madam is Director at Revival Medical Center, Bhilai, India. I welcome Dr. Sangeeta Sinha ma'am. Ma'am, are you there? Am I audible or visible?
Yeah, you are audible. Shweta, you
I
are
think
audible.
Dr.
I think
Sangeeta
Dr.
Sinha.
Sangeeta
Dr.
Sinha ma'am is not here, so you can ask Dr. Monica Agrawal ma'am to introduce the.
Hello.
Okay, I
Yeah,
welcome
Dr.
Dr.
Monica.
ma'am.
Uh,
Dr.
now I
Monica
would like
Agrawal.
to introduce Dr. Yeah, I would like to introduce Dr. Bharti Dhore Patil. She is the HOD Shri Hospital Pune, IVF consultant Nova Fertility Pune. She is the National Vice President IFS, National Vice President Foxy 2016, President POGS 2018 to 19, a past President of IMA Pune, ex-chairperson Clinical Research Committee Foxy, National Corresponding Editor India Obstetrics and Gynae Journal 2012 to 2016. She was the founder, Chapter Secretary, Maharashtra Chapter IFS, Executive Editor, Journal FSR, Fellowship Guide for Postgraduate Reproductive Medicine Fellowship IFS ICOG. She got the Pune Women Icon 2014, Foxy Star Awardee 2016, and an Inspiring Gynecologist of India 2018. I think Dr. Dhore Patil is very popular among the gynecologists. So
Thank you. Thank
I
you.
would request her
Monica.
to start with a talk.
Yeah. Thank you very much. Indeed, it is a privilege, Dr. Monica, you to introduce me. And thank you. Dr. Sinha is there, I think. This was actually wonderful opportunity, has been extended by Prakriti. So very hardworking. The person
Thank
who
you so much.
catches me is very, very hard. So Prakriti was so much, and I think Chhattisgarh IFS chapter has done wonderful job. Association with PCOS SIG group of IFS.
This
Wonderful evening, and
first association of
hello, you've been not audible.
chapter.
Yeah.
Yeah,
Hello?
actually, ma'am, this is the first association of with the. I am audible.
Yes, yes, yes. Now you are audible.
I wanted to say that it is the first association with SIG. Any SIG we have not done previously with the Ifs-Cg chapter. So
Yeah.
it's the first webinar with the SIG PCOS.
Yeah, you will be surprised after we discussed and we thought of this CME. The next day we had IFS executive meeting, and then in that meeting everybody said we must have collaboration with the chapter and the SIG group, and that was wonderful. I said we are going to have in 20th January. This is because of Prakriti. So thank you very much. Am I audible? Hello?
Yes. Yeah,
Yes,
you are
ma'am.
audible.
Yeah, ma'am, audible.
Can I share the screen now?
Yes, ma'am, for sure.
Yes, a second. Is it coming? Is it?
The screen is coming, ma'am, but
Slides are not there?
slides are not there.
Hmm. It's okay now?
Yeah.
Perfect, ma'am.
Yeah. Okay. So now.
Click in between the slide once, ma'am, and click on next. Yes, ma'am.
Yeah. I think I don't want this upgrade to be seen here. So how to do this?
Ma'am, at our end, it will clear. No issues, ma'am.
No, but something is coming over here in my.
Just make it full screen. Yes, ma'am.
This is okay for you?
Yes, ma'am. Perfect.
Yeah. So today we are going to see how this PCOS with insulin resistance and hyperandrogenism, how they are linked and delinked, because this is actually the pivotal role which they have been playing in the PCOS understanding altogether. So we'll start with, I think this my screen now is not being complete here. Something has come here, upgrade on my desktop. I'm so sorry. Wait a minute. Because I can't see my full slide then. Hello, any technical person?
Yes,
See,
ma'am.
somehow it is come that Zoom apps is only available and this upgrade they have been saying, but I don't want actually to upgrade this, but somehow it has been coming. Can I just
Okay.
stop and
Ma'am, just cancel out. You just cancel out.
no, it is not even canceling.
Okay. Okay. Ma'am, just give me a minute. Just give me a second.
You don't see na this?
I can see this.
You can see this upgrade.
No, that upgrade is not seeing here.
That's what I'm saying. I'm only seeing, and that's what. If suppose I don't keep a
Ma'am,
full
please,
screen,
can
is it
you
okay
please?
for everybody?
Ma'am, yeah, you can send it to Abhishek and he will
Yes.
share it.
No, that is okay. But suppose right now, if I don't do the slideshow, is it okay for everybody?
Yeah,
No,
yeah. Yeah, it's
shows very
okay.
small screen. See, suppose like this, nahi, but still it is coming.
Ma'am, it is visible actually.
No, but for me, na, the
It is
slide is
coming,
not
it is visible,
visible.
ma'am.
For me, the slide is not visible completely. See, half
Oh, okay.
portion. 1 second. Now it is. I think I've done it. Yeah. Okay. Yes, now it's okay. Yeah, now I'm.
Yes.
So we start with, say, 29 years old patient comes to us for consultation 3 years after marriage, and she's been diagnosed as a PCOS. You all know that. People now comes that I have a Pcos doctor, and how she wants to plan her obstetric career, like pregnancy, what way she has to go ahead. She's been asking us. She has a irregular cycles. Her BMI is 30, and her sonography is suggestive of polycystic ovarian morphology with thick stroma. This is what is mentioned on the sonography. Her AMH is 10 nanogram per ml, and her features is suggestive of hirsutism. That's grade 10. That means whenever the hirsutism, the hair growth, which is normally you see on the upper lip, and we see extending on the ear side, you see like little of a beard or like that way. But whenever they have hairs, say in between the breast or in the abdomen near the umbilicus, or she has a hair growth on her scapula, the score starts going up. So just ask any patient that if you have a hair growth, do you have hair growth in between the breast, on the scapula, or near the umbilicus? So this is how you will understand the severity of hirsutism. It's a very easy, because you don't go for that FG score, and this all becomes very, very tedious and tricky for us. The patient had acanthosis, that is also grade 1, because we should know now acanthosis is not to be taken very lightly, whether it has got a grading, whether it is a thin, a very thin blackish discoloration, or you see sometimes it is a wave, you can say velvety, or you see a very dark patches, and you see in between the dark patches you have a lines coming. That means there are folds. So this is the way acanthosis has to be graded also, and then you will understand which type of PCO you're dealing. So acanthosis, she had grade 2, and with acne also she had a grade 3. How do you grade the acne? So acne which is only simply they're coming and they're getting disappeared. The acne which has got the sebum inside, or sometimes it has got pustules, and they leave the marks. If they have the marks remaining on her face, that acne is of grade 3 or grade 4. So start right now after this webinar understanding your patient having hirsutism of what grade, acanthosis of what grade, or the acne is of what grade. Depending on that, you will understand that this patient you are dealing has a hyperandrogenism or insulin resistance. She had a normal male investigations. So let's understand different phenotypes and how will you manage, because that's very crucial for the patients coming to you. So how do you know the phenotypes? This is a very easy picture you can keep on your table, because if you start intermingling many features, it becomes very difficult for you to understand how to go ahead about the management of that patient. All PCOS patients are not same patients. all PCOS patients don't keep in one basket. They are different. They have completely different way of presenting to you. They're completely different the way they have inside their body things are going on, because it is inside the metabolism which has been problematic. And the features which are coming, maybe sometimes you don't see them very properly. So it is very difficult and complex. And that's why PCO is intriguing. And PCO always, everybody wants to listen about the PCO or understand the PCO. So irregular menstruation, that means one corner you keep a menses, menstrual cycles. One side you keep hyperandrogenism, clinical or biochemical. In menstrual cycles, you keep regularly irregular cycles or irregularly irregular cycles. So very easy, you keep these things in the mind. Then coming polycystic ovarian morphology and the sonography, like 15 or more follicles, that they are ranging from 2 to 9 millimeter, and ovarian volume more than 10 centimeter per square. Either of these three, if you have two criteria, that means this patient is being diagnosed as a PCOS. Other causes definitely of ovulatory dysfunction and HA should be excluded. That all we know that TSH and prolactin and this all should be excluded in this patient. So like this, if you get the three criteria in front of you, you will get one phenotype which has irregular menstruation, that menstrual problems, and hyperandrogenemia. In one type phenotype, you will get HA plus PCOM. In one phenotype, you will get IM and PCOM, and one phenotype you will get all three. And now how do they identify that? I'll tell you over a period of time. So this is how the four phenotypes will come in front of you. We know this is a very complex problem because 75% of the obese women has got impairment of the insulin action. And this has been measured by gold standard methods up till now. The insulin resistance and associated hyperinsulinemia can induce both endocrine and reproductive traits. Now, what do you mean by insulin resistance and associated hyperinsulinemia? Resistance means in the receptor level, at the receptor level of insulin entering into the cell, there is a resistance. And because the resistance is there, the insulin which is circulated in the blood supply or in the vessels is not able to enter in the cell to act. So it is not going inside. That's why it is abundance in the cell, in the vessels. And that's why it is called compensatory hyperinsulinemia. Not exactly, she doesn't have the hyperinsulins in her body. PCO have a number of vicious circles and bidirectional relationship between androgen excess and the insulin resistance. So it is bidirectional, means we don't know, it is very extremely difficult to understand where the process is exactly originating. Is it a HA first or is it a IR first which has been causing this all complexity? Androgen excess in turn can impair the insulin action directly and through the several changes in the different tissues. So maybe insulin action is very important in the patients who has androgen excess. Body fat excess is also another common feature which is actually contributing to this all features altogether. So hyperandrogenism causes a series of pathophysiological changes, including insulin resistance, hyperinsulinemia, dyslipidemia, unbalanced LH and FSH ratio. See, I'm not saying raised one now here. I'm saying here unbalanced LH and FSH ratio. We'll tell you how this is related to your clinical practice. These changes not only singly promote PCOS development, but interact to form the vicious cycle, and that induces PCOS. So this will be very, very easy for us to make patient understand in our counseling. Hyperandrogenemia and hyperinsulinemia and obesity blocks the development of the follicular growth in PCO. And the most of the follicles gradually arrest at any stage of development. And this is how patient will keep on asking me, what does exactly happens to the follicles? It gets gradually arrest because of these three things together. And this gives a disordered folliculogenesis. Like many a times you see the follicles are just not budging, or many a times you see they have been just going ahead without your knowledge. They have been hyperstimulated completely. So this is all is basically because of HA, then IR, and abnormal reactive oxygen species and inflammatory cytokines, especially in the patients of obesity. So IR and hyperandrogenemia within the setting of PCOS can establish vicious cycle, and that stimulates each other. So the confluence of endocrine and metabolic alterations also provides the basis of this, and this is the way it complicating the metabolic therapy, this complication will give rise the explanation for the metabolic therapy. So now what about the patient who has no hyperandrogenemia? We have seen the patients, especially Southeast patients. You see Chinese or these all type of patients who have no hirsutism at all. They don't see completely plain face. They're very, very good. And still, or you see in the village area of ours in India, we see the patients who have a irregular menstruations and a polycystic ovarian morphology, so big ovaries you see, but you don't see hyperandrogenism in these patients. So how it has been related is a wonderful article in 2020 was been published. So PCOS without hyperandrogenism is associated with higher plasma trimethylamine N oxide levels. And this is very important because this associated the pathogenesis of PCOS without HA, and it correlates. How it correlates is increase the systemic inflammation in this patient. And because of that inflammation, we know that what happens, we have just now seen in the previous slide. So it is not this way, but the cycle is going from this end to this PCOS patient. That's how, even if androgenic society was not agreeing to this feature that this should not be included in PCOS, but it has still place in the Rotterdam's criteria is because of this study. So let's go further now. How can you subdivide now PCOS? Let's simplify the things, and we divide to one is LH driven PCOS and another is insulin driven patient. Insulin driven, LH driven will be patient who is slim, you see, hypoestrogenic, this patient. So all PCOS are not a hyperestrogenic patient. So it's a slim patient. She has a high LH, she has a high impaired GTT, and she responds best to the ovarian diathermy. Now, these patients, if they are slim and hypoestrogenic, your letrozole will not work in these patients, because letrozole or aromatase inhibitor will reduce your estrogen to further down, because it is too less estrogen because of the aromatase inhibitor. What happens? First of all, they are hypoestrogenic, and on the top of that, you are making it estrogen low. These patients will get breakthrough bleeding, and you see a thin endometrium in these patients. So identify these patients and then treat them accordingly. Now, insulin-driven patients will have a central obesity, acanthosis nigricans. But nigricans also has to be seen with the grading, and then you will understand how to counsel the patient that if you have a severity, you need to optimize that patient more better. She will have a longer intermenstrual interval. She will not have something around, say, 1.5 months or 2 months, but she may get 3 months or 4 months, and down the line she'll get the menses. Or many a times she will have irregular cycles. Then she will have an altered OGCT. So now the decrease in the level of fasting insulin, as I think Dr. Sinha was been discussing right now, is recorded by PCOS treated women with insulin sensitizing medicines. And that appears indirectly even hyperandrogenemia also. So how does this happens? It happens because it increases ovarian functionality. At the moment your ovaries start functioning more, you know that your androgen is definitely go down, your stroma is going to go down and down and down. And this is how insulin sensitizing molecules are very, very important in the PCO patient treatment. And this was a wonderful article. You can go through. This is available on net, this is in the Life Science Review article 2019 said, hyperandrogenemia and insulin resistance is the chief culprit of the polycystic ovarian syndrome. So now coming to these 4 very, very important phenotypes on the sonography. How will you identify? All PCOS are not same PCOS. Now, if you see right corner, you see a PCOS. If I ask you which PCO you will like in your practice, or you feel that is a okay, easy for tackling the PCOS. Majority of the delegates, when I ask them in the actual conferences, they say this PCO seems to be better, where you see a dominant follicle. Of course, it is correct. Now, this patient has a PCOM, but she has no irregular menstruation. That's how she has a dominant follicle. That means this PCO is going to ovulate very nicely. Now, if she ovulates, of course, she will have a chance of pregnancy, and she easily conceives in this type of a PCO. Now, what happens to these patients? If you don't understand her behind mechanism which is going on of a hyperandrogenism, this patient will go into early menstrual loss. So early pregnancy loss. So in this early pregnancy loss, you have to avoid that loss, and we must tell the patient that PCO patient is difficult to conceive and difficult to maintain. So this PCO in that way is different. Now coming to this one on my right side, the lower side, you see a very nice follicles are there around, but these all follicles are measuring 6 to 8 millimeter. We say 2 to 9 millimeter is our range. So they are 6 to 8 millimeter. Looks very nice to us. And she has a very thin stroma. Doesn't look very bad stroma. This type of a patients, we will have probably not irregular menstruation, but they will have hyperandrogenism. These patients very easy to stimulate, very easy, but will go into hyperstimulation very quickly because they don't have that big stroma and their follicles is 6 to 8 millimeter. So in these patients, your low dose protocol is very, very important. Now coming to this one on the left side and the down, is it been seen? Sorry to interrupt. Is it okay? You are all following me?
Yes, ma'am.
Yes,
Yes.
So the left side, you see the down. These follicles are 2 to 4 millimeter follicles. They are not 6 to 8 millimeter, isn't it? So these follicles are very small follicle, but look at the stroma, which is a very thick stroma. So whenever you see that this is a very typical PCO and she will have all 3 phenotypes together. It's very difficult to treat this patient. She will have a very high threshold. Patient will require a very high doses of gonadotrophins, or even if you're giving oral medicines, but she will require very, very large amount and she will not budge. Or maybe many a times you'll see no ovulation, no follicular growth in this type of a patient because they have a high threshold. So we go with the norm from all the CMEs that low dose PCO, but this type of a PCOS, low dose will not budge. It will not work. She will require a high dose depending on her BMI. You increase her dose, she responds very well. And if she responds, believe me, they give a best pregnancy outcome. Now the last one, which has been on the left upper corner, you see to call it is a PCO or not to call it PCO. Many times different sonologists or different gynecologists will give sometimes diagnosis PCOM, sometimes no, because you see there are no follicles very continuously each other aligning, but they are there. They are 10 to 15 follicles and there is a very thick stroma. These type of a patients, usually you'll see when the patient is crossing a PCO patient, but crossing 35 years onwards. 34, 35, 36, 37 years patient will have this because the number of follicles will reduce, but her hyperandrogenism will increase in fact. In fact, once she goes ahead with her age, her peripheral androgen secretion will increase her hirsutism, and this will be adding into the fuel in this type of a patient. Very, very difficult to explain the patient. stimulation will be difficult, and you will get very few follicles. Whenever you see stimulation, you'll get a very few follicles, and you'll wonder, इसको तो PCO बोला था, ये तो 4 या 5 ही निकाल रही है. And she will have a very less number of eggs. So this type of a PCOS, you have to understand and make them treat accordingly. So we know that PCO patient will face infertility, ovulatory dysfunction, miscarriage, multiple pregnancies, hyperstimulation, and a pregnancy outcomes. So therapy currently considers both lifestyle improvement and the medication, but very importantly, each patient has to be tailored on case-to-case basis. And this is how you will go on understanding how the patients has to be managed. We all know if the patient comes with the infertility, this is a conventional ovulation induction protocol, WHO2 type. We know that oral medication should be given in the beginning, and then it is not working, you give a gonadotropin, then see the response, and if the pregnancy is there, that's fine. But in case if it is not, you go to level 3, and that is IVF. Now, what my intention of putting this slide was, alternative therapies or strategies also to be given to the patient. But what my intention was, like, when will you jump this patient from stage 1 to stage 3 directly, or stage 2 to stage 3 directly? I will completely take out stage 1. This is very important paradigm shift now in the PCO patient. We have all listened this WHO type 1, level 1, level 2, level 3, and we fumble when the actually patient comes to us. Or maybe patient changes the table. By the time you understand that this patient is not responding, and the patient goes to the other table and she starts gonadotropin, and probably she gets pregnancy. So this should not happen. So we have to understand, depending on the phenotypes, some patients, like if I told you that patient who has a high threshold and a resistant PCO and a hyperandrogenic PCOS probably has to jump to IVF directly, override that PCOS. That will be the strategy for that patient. Her taking time for the pregnancy will be very, very less. Otherwise, you keep on 3 cycles, these 3 cycles, that, and then another 2 cycles in between laparoscopic drilling. She will take longer time for getting pregnancy, although she had a number of good eggs, but still. So step-by-step approach of ovulation induction would be weight loss, then clomiphene citrate, aromatase inhibitor. You can jump to aromatase inhibitor straight, but to remember, 2.5 milligrams, say 5 milligram gives the better outcome for the patient. Insulin sensitizers, or in the combination gonadotropin and insulin sensitizer, ovarian surgery, LOD or IUI, IVF. So these all things step by step you can do. Now, very importantly, we all know that we listen from so many speakers and topics that ovulation induction, you all know, very familiar. What happens this PCO patient in the latter age? So now the latter age of their life is very, very crucial for them, and where patient is detached from us. The moment she is pregnant, she's get detached from us because she is in the family then, and she doesn't even remember also what she had unless she really faces irregular menstruation. Second patient who will keep on trying clomiphene citrate, aromatase inhibitor, gonadotropins, and she gets exhausted and she lost the interest and she completely loses everything and she gets disappears. And she lives her life without children, without anything. And she doesn't even understand. She doesn't even want also to know that I had that Pcos. I don't want to do. But we have to understand these patients very importantly to make them primarily understand their value of taking care in the later age. Coming to 48 years now, this patient, suppose she has our good patient who's been conceived, she had 2 children, 1 abortion, the same patient with our all efforts of ovulation induction she had. And now she had actually come to you and she's worried about the irregular cycles and obesity. She's just simply putting on weight. So what investigations will you take, advice for this type of a patient, and how will you manage this patient? And what happens in her perimenopausal stage is very crucial to understand. So can women still have PCOS when they are peri or postmenopausal? Yes, it is lifelong disorder. Some assert the PCO disappears after menopause, but actually it continues to be the problematic in the patient during and long after the menopause. So we have to be understanding this. For some, could you please excuse me? Somebody's ringing the bell. I'll just come. I'm extremely sorry, but somebody was knocking my bell so long. So for some women with PCOS, is it okay? I'm audible?
Yes, ma'am, you are audible.
Yeah. In some women with PCOS, many of their symptoms are like excess hair growth, hair loss, weight gain continues in their later age. And other women, some of them with the PCOS symptoms do improve after the menopause, but it doesn't leave. It doesn't leave. That PCO never leaves them. How I'll tell you. So there is a surprising lack of research on the PCO after menopause, and that can be very difficult to diagnose also and monitor also these patients. Because one of the main symptoms of PCOS is menstrual irregularity, and menopausal, you all know that there is menses only stops. The using a measure of testosterone or DHEAS blood levels to diagnose or monitor is again less informative, because SHBG levels, this is a very, very important statement. SHBG levels tends to decrease in the menopause. So whenever a patient comes after 35 years of age, or maybe 50 years onwards, you don't measure their SHBG because they definitely tend to decrease in the menopause. That leads enhanced activity of free androgens. Many a times you must be seeing the patient who is come in the 50s and 55s, and they say, suddenly, doctor, my hair growth is too much on my face. This is because her SHBG level starts decreasing, so there is no binding, and the free androgen starts circulating. So the androgenic effects of these hormones can therefore becomes more prominent in the menopause, regardless of whether or not the menopausal woman has PCOS in the previous time. So these are all long-term PCOS risk, mainly CVD, gout, then obesity, gallbladder disease, endometrial carcinoma. All these are very important to understand. So the long-term health consequences of the PCOS is very, very important to understand, and how to minimize and prevent these consequences. Blood investigations. Now, in these patients, what will you do? So first, you rule out the diabetes by giving the blood test. Straight away, you can go for fasting PP, and you can HbA1c. Sonography, very importantly, to rule out whenever a PCO patient in the latter age of life comes and she has a heavy menstrual blood flow and her endometrial thickness is more than 12 to 50 millimeter, yes, you must undergo the endometrial biopsy along with your hysteroscopy to rule out atypical endometrial hyperplasia. Cardiac assessment in this patient is very important if they have a cardiac element. So there are three possibilities. That is definitely long-term sequelae are there. There are few possible sequelae are there, and few are still controversial. So let's see one by one. The definite possibilities you can counsel to the patient is type 2 diabetes, dyslipidemia, and endometrial cancer. This is not going to leave them. Possible, they may have a metabolic syndrome, obesity, IR, and gallbladder diseases. Cerebrovascular diseases, coronary cerebral and hypertension, depression, anxiety, and loss of self-esteem. Obstructive sleep apnea is very, very major thing which can happen as a long-term consequences of PCO if she doesn't understand how to control the weight. And very importantly, epilepsy. So women presenting with PCOS, BMI more than 30, age more than 40 years of age, and a positive family history of diabetes, 77% of the women with oligomenorrhea have evidence of PCOS, and 33% have an abnormal glucose tolerance. So the woman should be offered glucose tolerance test every yearly. Snoring and daytime fatigue is very, very important to be noticed in this patient. And please inform her possible risk of sleep apnea, especially in my practice. I call her husband or the relatives and tell them, you have to be careful, don't leave her alone when she has been sleeping. So conversion of IGT, impaired glucose tolerance, to type 2 diabetes is very, very high. And this is substantially enhanced in the patient of PCOS. Controversial, PIH, miscarriage, ovarian cancer, and a breast carcinoma. In the metabolic syndrome, you all know that out of these five, if you have 3, then you label that patient as having a metabolic syndrome. Probably these patients don't come across to us because by this time they go to endocrinologist or they go to the physician. They don't usually come back to us because after the delivery, usually we lose the track of the patient. That's how we don't see this type of patients. Prevalence of MS in PCOS is associated with decreased fibrinolysis, increased C-reactive protein levels, and increased carotid intimal thickness. But usually, even if it is 2-fold higher than the women in the general population, we don't see them because we do not look at them unless they come with the symptoms like irregular menstruation, or she has a heavy menstrual flow, or she has something related to her gynae problem. And that's how we don't understand the prevalence of this patient. So this is how the PCO sits in. And this is how we should understand that hypertension, if she has, if you not patient, but our own family members, if she has been diagnosed, hypertension should be treated aggressively. Like you should not be sitting 130/90, chalega, okay, doesn't matter. But she has to be aggressively looked into it. Lipid profiles are mandatory in this patient. And whenever a patient has irregular menses with high estrogen levels, almost 53% increase in the CVD events has been seen in that nurse's health study. So high estrogen level and irregular menstruation will be depicted how on the sonography when she will have a heavy menstrual loss, or she will have more than 12 to 13 millimeter of endometrium. This patient you have to understand. Cancer at risk at PCOS, amenorrheic or severely oligomenorrheic women with PCO should have induced withdrawal bleeding at regular interval to reduce the risk of developing endometrial hyperplasia. Usually, I think we skip this for these patients. Okay, abhi nahi period aata hai, it doesn't matter. Keep on going. But no, if they are amenorrheic and they had a PCO history, they should regularly shade till the end. There's no association with the breast and the ovarian carcinoma because we have not still had a more surveillance. We may need more surveillance. So how to minimize or prevent long-term consequences? Lifestyle modification. First of all, remember that you had PCOS. So don't ignore that. No, we get carried away. We said, no, we don't want now that. Once you get pregnant, we don't want to know also we had a PCO, but no. That is very important for us. 5 to 10% of the loss, weight loss is very important for the regular ovulatory cycles. Calorie restriction is very important than the dietary composition. This is very, very important. What I tell in patients in my practice is whenever there is a dietary modification or whenever you say diet follow karo, तो बहुत difficult है diet follow करना because they have a habit. Once you have a habit, it is very, very difficult. So I always tell them, you need one quote I give them from Guru, this Gopal Das book. So I'll just read it for you. stop and reflect on your life regularly. This is what I always tell them. You have to stop and you have to reflect on your life regularly. So what will you do when you actually modify your diet? Start cutting down the portions. Probably you are very fond of pizza. Fine, doesn't matter still. But when you are eating full pizza, now you start only one piece of pizza. So calorie restriction is very important, because it is very difficult to make people completely change the dietary composition. Exercise improves definitely insulin sensitivity. Both aerobic and resistant training is very beneficial. But how many of us go? Especially when you have been more than 40 or 45, very rarely we go. So what can you do? At home, do some work which is going to give you the exercise. So start that compulsory, that work is going to be happening through you. That makes a lot of, say, climbing the staircases, or cleaning your balconies. You have to, or simply cleaning when you take a step and then clean, your hands goes up and then you start pulling that and you clean that. Regularly clean the cupboards. These all exercises makes a lot of difference. Genetic expression of PCOS can be optimized and modulated by prevention, the interaction between the genes and epigenetic factor. This is always I tell them, okay, fine, you have came with the coding of PCOS, but that coding of PCOS can be changed with your lifestyle modification through epigenetic factor, because we know there are histones which are being enveloped onto the DNA, and the histone has open ends, and they listen and they modify your genes. And once you make them understand, the counseling makes a lot of difference in them, and they start understanding, oh fine, even if my genes also, I can modify them. So management, intensive lifestyle changes, then all these medicines, metformin, as I just now was been discussed, it is very favorite of mine. You must give metformin because insulin sensitizer is very important. Now one question was there, the metformin or myoinositol or D-chiro-inositol, which one is better? Both has different actions. Metformin is actually the insulin sensitizer, works on your receptor level. So whenever the receptor level is being problematic, this works best. But when it is a cellular mechanism inside your enzyme modulation, your myoinositol or D-chiro-inositol will work better. So probably both are better. Both, if you can give combined, is the best one, but you should see the tolerance of that patient. So insulin sensitizing drugs definitely improves the sensitivity, improves the glucose tolerance, may reduce serum testosterone, and reduce the plasma PAI and CRP levels. And thus, you know that early pregnancy loss can be actually avoided. Insulin sensitizing drugs in IGT and GDM basically prevent the progression to DM and may decrease the CV disease. How we tell the patient, like, even if suppose you are not needed right now, any infertility treatment or anything, probably you should keep looking at your OGCT, and your impaired glucose tolerance means you are pre-diabetic. You are completely full-blown diabetes nahi hai, but you are pre-diabetic. So if you keep on taking the small doses of insulin sensitizing drugs, definitely helps, but your diagnosis is very important. So in nutshell, PCO androgenism has a convoluted etiology, closely linked to the ovaries and a suprarenal. The development of systemic diseases in PCO can be influenced by HA and IR. They are intricately connected to breeding process like obesity, hypertension, non-fatty acid liver diseases, dyslipidemia, sleep, neuroendocrine issues, apnea, AGA, EDC impacts. PCOS is usually identified by irregular menstruation or infertility in young women, and PCO can in its later phase create a range of metabolic problems, must be remembered. Cognitive and behavioral pathways are likely to be involved in the PCOS, and because of their distressing symptoms like anguish and despair, smoking, excessive alcohol use, and inactivity is widespread, especially in the later age. So timely training and intervention definitely improves one's quality of life. So infertility in oligohypomenorrhea represents only the tip of iceberg of the PCOS, but later sequelae are hidden serious base. So treating the whole state rather than the symptoms should be the principle on dealing with PCOS. Hare Krishna, thank you very much. And I'm open for the questions.
Thank you, madam. Your topic and your discussion was very, very fruitful at first. I think it will be very useful for us. So any questions?
Madam has answered almost all queries
Really,
in her lecture.
So this should be, because webinars should be a practical base, like, people are taking time out and they've been coming over here. So they usually should have a take home message, like what?
Ma'am, I always find difficulty in treating lean thin PCO, because in especially of rural area, because they are doing lot of work. We need to just give a thought before starting metformin. They do lot of physical work, तो hypoglycemic होके गिर ना जाए और इस तरह से. What is your experience in that cases?
No, you should give them, but it should be not the doses what we say. They say maybe 500 milligram 3 times a day. The patient who are thin patient, they do not require that great dose of metformin or insulin sensitizers. Thin patient, usually what I feel, rather than resistance at receptor level, their cellular mechanism is not good. And you must maybe understanding, you may be knowing that these village girls, mainly their 1 or 2 types of carbohydrate they eat. Their protein consumption is very, very low.
Yes.
And there's mainly, you will see that wo roti khayega ya ek sabji khayega, but or rice khayega, something like that, So their cell mechanism is not very good. And that's how I feel they're enzyme deficient, that conversion. They've not been able to do that P450 enzyme conversion. And that's why those patients will be more benefited with myoinositol and D-Chiro. And you will not be uncomfortable also for, hypoglycemia or anything. So those patients, you give that.
Okay. Thank you, ma'am. Thank you.
Madam, one question. Is there any special case where you prescribe both metformin and DCI-MI?
Usually in the patient who are obese patients.
Yeah.
Obese patients. And still those patients who have a very resistant ovary, like they have not been ovulated at all. These patients, I give both. Many a times patient who doesn't tolerate metformin 3 times a day, 1,500 milligram, this patient.
Okay.
So then I reduce the dose of metformin and add that. So this kind of a patients I manipulate.
Okay.
Somehow insulin sensitizer are a mainstay in my practice.
Okay.
So I don't usually go as people are saying OGCT should be altered. It is very difficult for these patients OGCT alter, because see what happens, we give 75 grams of glucose and we ask them to withdraw the blood after 2 hours, and then you oral glucose challenge test. How many of us very systematically give that 75 grams of glucose? First of all, we don't. We just say that tum khao or khana, but khane ke baad composition of your diet is totally different, and it is going to come out completely different results.
Yeah.
But if at all you do 75 grams very seriously and ask her not to do any activity, 2 hours she has to be at least sedentary life. Like, her body should be, if she starts going 75 grams and she starts exercising, it is not going to, useful for us. So like that, that's how OGCT, I see overall patient, I go more on her hormonal profile and her sonography. My sonography is very, very important.
Yeah, sonography part is very...
sonography and her features. As I told you, I don't see just acanthosis. Just don't see the acne, or I don't see just hirsutism. I must grade them. Grading is very important for these patients, because this is actually peripherally it is coming out, isn't it? That androgen, and which has been depicting. So this is platform. This is an easy platform for us to understand her. These all things are going on. I always tell them, तुम्हारी बॉडी में तो युद्ध चल रहा है और आपको तो पता ही नहीं चल रहा है कि इतना बड़ा महाभारत चल रहा है अंदर आपके, ये बाहर दिखता भी है तभी भी पता नहीं चलता. So it catches their eyes and they start following anything. So this is how I tell them. I'm very particular about the diet.
Question.
Yeah. Yes.
Good evening, madam.
Good evening.
Madam, as you have rightly pointed out that in menopause, these sex hormone binding globulins, they decrease, and this is the main reason why these females are getting hirsutism. So so how to treat, besides all what you told in receptors and all those things, supportive care, what to do next?
These patients, first of all, diagnose these patients whether they had PCO or non-PCO patient. Very importantly, like if she has a past history of PCOS, probably this patient will get the regular anti-androgens, and that both the things will taken care of, irregular menstruation as well as her hyperandrogenism. If the patient is non-PCO patient, like still she will have 45, 50 years or 55 years there. So those patients I'll give cyproterone acetate or maybe flutamide for this patient, because they don't require now any estrogen or anything. They don't require that. So like this, I will divide those patients, PCO and non-PCO patients.
Okay.
Ask them the history prior, because they know whether they have a PCO, pehle wala kya tha. Agar suppose they don't have, they don't know, you ask from the beginning, say you started your menses. This is a key question you can ask them. When you started menses, how was it? So she'll tell, first 2 years it was okay, doctor, and then it started irregular. This is a PCO patient, like that. Or she'll say, तो पहले से ही मेरा बहुत irregular, कभी था, कभी नहीं था, कभी नहीं था, इसको छोड़ दो आप. तो इसको नहीं, because PCO patient initially they'll be okay, and then everything will be disturbed for them, and then it is so much disturbance that they will understand this. और they will tell कि ये मेरा black हो रहा है, या dark patches आ रहे हैं, ये पहले से ही था, kind of that. और मेरे को acne बहुत थे. So this all will correlate whether she has PCOS.
Thank you, ma'am.
Thank you.
So thank you very much.
Thank you for
It was very good, when I started preparing this lecture.
Thank you so much, ma'am. It was very nice
Lot
lecture.
of literature I went through, and Prakriti, because of you, this happened. So I always tell everybody, pressing the pause button to practice the gratitude is the key to make constant feature in your life. So हमेशा pause करो life में, gratitude बोलो आप लोगों को जो आपके life में आते हैं या किसी की वजह से आप करते हो, ये आपका सबसे बड़ा feature होना चाहिए. So thank you so much.
So nice of you, ma'am. Thank you so much.
Thank you.
So Prakriti, do you want me to stay back?
Yeah, ma'am, you are in the experts of panel discussion.
Okay, done.
Thank you so much. Thank you so much, Bharti ma'am, for elaborating the topic so nicely. Now moving to our next session, panel discussion. The topic is ovulation stimulation protocols. I welcome our moderators, Dr. Ridham Gupta ma'am, Dr. Neeraj Pehlajani ma'am, and our experts, Dr. Bharti Dhore Padil ma'am and Dr. Preeti Agrawal ma'am. Dr. Ridham Gupta ma'am, Madam is consultant reproductive medicine and surgery, Excel IVF, Shalimar Bagh, Delhi. Madam is MBBS, MS, DNB, and fellowship in clinical ART. Madam is co-convener, PCOS SIG Indian Fertility Society, executive member of Indian Fertility Society, and treasurer of Delhi Gynecologic Forum. Madam has received so many awards, including APJ Abdul Kalam Appreciation Award in 2019. And Madam has a special interest in PCOD, oncofertility, and poor ovarian reserve. I welcome Dr. Ridham ma'am. Now Dr. Neeraj Pehlajani ma'am. Madam is MBBS, MS, DNB in Obs-Gynae. Madam has done DRM from Cal University, Germany, and fellowship in IVF and embryology from US. Madam has trained in laparoscopy and hysteroscopy from Cleveland, USA. Madam is clinical secretary, CG ISAR Raipur chapter, and pioneer research leading to new insights into important clinical problems related to infertility. She has received award with the innumerable laurels by Honorable CM of the State of Excellence in IVF and eminent contribution in the field of women health. I welcome Dr. Neeraj ma'am. Our experts are Dr. Bharti ma'am, as we all know very well, and Dr. Preeti Agrawal ma'am. Dr. Preeti Agrawal madam is MBBS, MD, FICOG, MICOG, FICMCH, FAMS, and DRM from Kelly, Germany. Madam is Director HOD, Arogya Hospital and Test to Baby Center, Raipur. She has laparoscopic surgeon and infertility specialist. And Madam has also been Associate Professor, Sri Balaji Institute of Medical Sciences, Raipur. Madam is Chairperson of CG Chapter ISAR and Organizing Chairperson of 6th National ISAR Embryology Conference, Raipur. I welcome Dr. Preeti Agrawal, ma'am. Our panelists are Dr. Anuradha Chaudhary, ma'am, Dr. Munmun Agrawal, ma'am, Dr. Rashmi Goyal, Dr. Preeti Upadhyay, Dr. Shilpa Pawar, and Dr. Madhuprita Agrawal. I welcome to all of you.
Yeah, thank you, Dr. Shweta, for a very quick and brief introduction of the panel and shortening our pain of introducing the panel. So very good evening to all of you. I, along with Dr. Ridham Gupta, invites you all to an interesting discussion over a topic which is ovulation stimulation protocols in polycystic ovarian diseases. We all know that ovulation stimulation or ovarian stimulation is like cooking dal, which have the similar ingredients, almost the same technique, but every other house dal tastes different. So is the ovulation induction protocols, that ingredients are the same, but everyone will taste that dal or will prepare that dal in different way. But ultimate idea is that you should take less of the time, maximum usage of your resources, and at the end dal should taste good and everyone should like it. So that is the idea behind the stimulation protocol. And we all know it's a double-sword edge. A little less may not give us the desired results, and we have to cancel the cycle, which is again a very painstaking decision, especially in today's world when the patient has become very demanding and impatient. Secondly, if we are going little over edge, means if the dosage are slightly more, or if the protocols are a little bit dicey, we may land up in ovarian hyperstimulation, or we may land up in bad quality oocyte. So we thought of taking this panel and whatever questions that we could think of plays an important role before stimulation, during stimulation, and after stimulation, which can play important role in the outcome. Thanks to Dr. Ridham, she has taken a lot of pain in designing those questions. And more important, we have our stalwarts with us who needs no introduction. Dr. Bharti Dhore Patil, Dr. Preeti Agrawal, they'll be acting like torch bearers. Wherever they feel that the panel is missing out some important point, or they are stuck up somewhere where they need to put up their expert views, please, ma'am, you are requested to intervene and give your expert opinion. So we'll start with the questions, and to begin with, Dr. Ridham will take the questions, and then later on I'll take over from her. Dr. Ridham, can you please start?
Yes. Thank you, Dr. Neeraj. Just a little bit brief introduction about our panelists that we have with us. Dr. Anuradha, she's consultant in reproductive medicine at Nova IVF Center, Raipur. Dr. Munmun Agrawal, she's a consultant working in Raipur. She's a postgraduate from SEB Medical College and MBBS from GMC Nagpur. She's an infertility specialist. We have Dr. Rashmi Goyal. She's consultant director of Apex Super Speciality Hospital and IVF Center, Raigad. Then we have Dr. Preeti Upadhyay. She's consultant director, Krishna Multi Speciality Hospital and IVF Center, Korba. We have with us Dr. Shilpa, who is an MBBS and fellowship in reproductive medicine. She's consultant gynecologist and IVF specialist and director of Santati Fertility Center, Raipur. Dr. Madhuprita Agarwal, she's consultant reproductive medicine specialist at Ashoka Advanced IVF, Raipur. I welcome you all, and Dr. Bharti has made our job very easy, and she has very emphasized on all the aspects that should be dealt with before we are actually looking at ovulation stimulation protocols in PCOS women. So starting with our first case scenario, there's this 32-year-old female with irregular cycles and has a BMI of 28 kg. The ultrasound shows bilateral PCO picture with an AFC of 20 on each side. She's married for 1 year and she's keen on conception. Dr. Anuradha, if she's there in the panel, she left in a while. Can you please elaborate on the preconception counseling that you would like to offer to such a woman? Is Dr. Anuradha there?
No, ma'am.
No, ma'am, she has left.
Dr. Monmon, can you please take up this question with preconception counseling?
Yeah, hi. So for the preconception counseling part, we need to go for a routine blood test, like her hemoglobin and her thyroid levels, vitamin D3 levels, her blood sugar. And then we can counsel her regarding, like we can take a look into her lifestyle, what kind of lifestyle she is living. So we can give her dietary modifications. We can ask her to add exercise in her lifestyle. And you need and then we can also go for a semen analysis.
Dr. Rashmi, would you like to add on something?
Good evening, all. Ma'am, in preconceptual counseling, as we see the ladies here above 30 years, so we should always counsel her for she's overaging, and so she should plan the pregnancy as early as possible. I'll counsel her, and then we should also ask her to for the importance of folic acid intake, and also she should be given vitamin D supplements to just improve the quality of oocytes. We can prescribe her, and lifestyle modification and other things we can just counsel her.
Dr. Rashmi, do you think is there any role of going for a detailed menstrual history?
Yeah, ma'am. Before evaluation, if we'll means, ma'am, you're saying for evaluation or
preconception counseling, is there any role of going for a detailed history and examination before jumping into labs and other things?
Investigation.
Do you think it will make impact on the stimulation protocol and its outcome?
Definitely, ma'am. We need to go into detailed history first, and then only we need to go for then proceed followed by the detailed examination of the patient, then followed by the investigation only. So in the detailed history, we should always look for ask for the pattern of cycle, as Bharti ma'am told that she is having regular or irregular cycles. Then we should also ask for the any drug intake history, like PCO patients are having hirsutism. So we need to rule out whether the hirsutism is due to PCO or non-PCO cause. So that drug history, whether she is taking any steroid or anti-epileptic drug, that has to be ruled out. Followed by the examination point. In the examination, we should always calculate the BMI of the patient, whether she is the lean PCO or the obese PCO. And waist circumference also we can do. Then in the detailed examination, we can also find out for the galactorrhea to rule out the hyperprolactinemia. Then about the skin pigmentation and all the other detailed examination, like if you are getting acanthosis, so it is associated with insulin resistance.
Anything that our experts would like to add on here?
Yeah, I think we should now start looking at the patient. What phenotype is she? So depending on her phenotype, if we start planning her pregnancy or whatever treatment management, so we divide the patient ovulatory PCOS and non-ovulatory PCOS. In non-ovulatory, whether it is a infrequent, hello?
Yes, ma'am, you're audible, ma'am.
So ovulatory PCOS, and still she has a PCO, that means she may suddenly become pregnant, but she will lose the pregnancy. So we have to understand that. And in non-ovulatory patients, you need to induce her. So we are not supposed to leave her alone. So divide the patients ovulatory, non-ovulatory, and depending on the phenotype, like whether she has a irregular menstruation and morphology, or she has irregular menstruation with HA, and whether she's thin and obese. So I think she highlighted those all points. So my point of question this was like phenotype is very important, and ovulatory and non-ovulatory, because she has come to you for conception. So we need to know whether her eggs are coming out and whether they are that quality eggs are coming out, so that it will be easy for us. I think Preeti may add anything.
Madam, I think everything has been very nicely elaborated, but one thing I would like to point, as you were talking of that this PCOS and preconception counseling. Now, as we can see, the BMI is quite high over here, means 28. So I would definitely suggest that these patients are also part of metabolic syndrome, which nowadays we are quite focused about. So at the same time, we should also go and check for their lipid profile. And definitely weight reduction is one thing which should be focused, because being 30 and then just going and telling her that, okay, you just get pregnant, your age is above, and then this patient will have all impaired glucose tolerance and she will be prone for gestational diabetes and so on and so forth. So basically, definitely lifestyle modification and a small amount of weight reduction is the first and the foremost thing that I would personally suggest to these patients. And nicely in 3 months time, and with these insulin sensitizing agents, these patients can lose approximately 3 to 5 kg weight in 3 months duration, and that definitely changes their prognosis.
Very rightly said. Basically, the idea is that in PCO, very rightly said, our experts, in PCO, we have to target two things. One is the oocyte quality, and second is the timely formation of the, means the ovulation. So whatever we are doing pre-stimulation will be targeting the quality of the eggs. And during stimulation, if our workup is good, then this response to the drugs will also be good, and also the oocyte quality will be good. As a result, conception rate will go high, miscarriage rate will go down. We should not jump to any stimulation until or unless we feel that the patient is good enough to start with the stimulation. Like in this case, we have already mentioned that the BMI is high. 10% reduction in the weight can have 4 to 5 times improved results in terms of the better follicular maturation as well as better quality of oocyte. So very rightly said, ma'am, that BMI should be focused on first, and that should be part of the preconceptional counseling with diet lifestyle modification. And Dr. Bharti ma'am has very well elaborated previously the role of insulin sensitizing agents as well.
So right, so when this woman is coming to us, it is our job that we spend a little more time in explaining her what PCO is and what PCO is affecting her body, not just about infertility, but otherwise what metabolic impacts PCO is going to have on her, and how is the path going to be. We have all discussed what are we going to counsel her, how we are going to investigate her, but there is some set timeline that we need to define for each and every woman who walks in with PCO as to this is the trajectory of your treatment that we are looking at. Apart from lifestyle, what becomes very important is weight loss is easier said than done. We know that whatever we may say that you go back and take 3 months time and reduce weight. For them, smart strategies are there. There are apps that help them to specific, measurable, achievable, and realistic and timely weight reduction. Not just that, emotional well-being of such a woman, quality of life, assessing her for any sleep disorders, body image issues, psychosexual problem, depression, and anxiety is also our first job at the first counseling session that we have for this woman. Moving on to what investigations we would like for her. Some of them have already been sorted by our experts. Anybody who would like to add on to certain investigations? We know that she's planning a pregnancy, so we have to evaluate her from prenatal point of view. Was there somebody talking?
We may do routine profile, like all the thyroid profile and prolactin, as we do it on routine basis, and then we can also do basal E2 FSH and LH level. Instead of if we are, as we are saying in this case, so she is obese, so we can also do fasting lipid profile to rule out the insulin intolerance, and also lipid profile, ma'am, should be included in this case.
Anybody who would like to get a tubal evaluation done apart from any semen analysis at this time?
As ma'am, the duration of marriage is only 1 year, so I'd like to do it later on, after trying 2 cycles of ovulation induction.
Yes, for a woman who is working in a clinic, just married for 1 year, who's trying for a conception now and is a known case of patient, probably we can definitely do an evaluation and just get a semen analysis done so that we know we need to treat the couple as a whole. Role of getting D2, FSH, LH, E2 and progesterone is probably controversial these days because that probably doesn't help us to categorize a woman as to which ovulation stimulation protocol we need to follow. Apart from the fact that we know without BMI and other things that she may have a feature of hyperandrogenism, and we need to deal with it individually, whether or not the basal LH levels are high. Day 2, day 3 pelvic ultrasound will rule out any functional cyst and will help us to measure the endometrial thickness, which is generally irregularly shed in a woman with delayed cycles. Dr. Preeti, I would like to know from you, what is your plan for induction in this woman?
Rhythm, I add AMH because I do the sonography, and looking at the sonography, I will categorize the patient, whether she's hyperandrogenic, whether stroma is thick. These patients, I do AMH because AMH will tell me, guide me how I have to deal with this patient. So AMH would be my investigation. Maybe the patients coming to us are not, they come to the fertility specialist directly in the IVF setup. So probably easy, but then AMH is one of the investigation. We do only 3 investigations: AMH, serum prolactin, and thyroid profile. That's it. We don't do anything else in the beginning, and a sonography. These are my 4 things, and along with blood investigations, routine one. These are the only 4 simplified things we do when the patient enters first time, like 1 year married life. But AMH is must in my investigations.
Rightly said, ma'am. Most of the women that are coming to fertility clinics are either investigated for PCOS in the adolescent phase or premarital phase. But for women who have never been investigated or walk into a gynecologist clinic, probably they have to evaluate them in a more thorough way and rule out other causes of hyperandrogenism also in them. And so, Dr. Preeti, how would you like to go for ovulation induction? This woman has already been put on to lifestyle management, and she's in the phase of reducing weight also. How would you like to proceed with ovulation induction in such a woman?
As patient is only married since only 1 year, and I will prefer the oral ovulation, and in that case I will prefer that aromatase inhibitor letrozole, because letrozole in the dose of 2.5 milligram to 5 milligram can be given, but as the patient was in the question, the AFC was 20 on each side. I would like to start with the 2.5 milligram from day 3 to day 7, as the letrozole, there is less chance, it will lead to monofollicular development, less chances of OHSS, and less chances of multiple pregnancy, and no effect on the cervical mucus and endometrium. I will prefer the letrozole. If no response, then I would like to add gonadotropin in sequential regime, like day 3 to day 7 letrozole, and day 8 onwards gonadotropin.
We'll come to that in a while. Just a second. So just talking of oral ovulogels, yes, it is a routine practice that we start with oral ovulation induction drug. And as rightly said by madam, that letrozole is the first line these days for various advantages that it has. Whereas I would agree to this fact that clomiphene is an older drug. It is being used widely by all practitioners, and it has also given us good results. But seeing to its disadvantages of hyperstimulation and multiple pregnancy and its anti-estrogenic effect, letrozole has definitely taken over. But we would have certain scenarios wherein, and this came out after a lot of trials that have been done between letrozole and clomiphene, wherein the pregnancy rates were better with letrozole. But yes, there would be situations wherein the oral ovulogens failed. So this woman was given clomiphene citrate 50 mg and there was no ovulation. And in the second cycle, 100 mg clomiphene was given, still there was no ovulation. So Dr. Shilpa, I would like to know from you that what is the maximal dose of CC that you use and what options does this woman has after failure of clomiphene citrate?
Maximum dose, if the woman does don't respond with the 100 mg of the clomiphene citrate, we can increase the dose 50 mg per cycle up to maximum of 250 mg. Although there is no advantage of giving above 150 mg. So I can give 150 mg of clomiphene citrate for 3 consecutive cycles. If she won't respond even after giving 3 cycles of 150 mg, we can consider as a case of clomiphene citrate resistant. So it's time to move to other ovulogen like letrozole. And starting dose of the letrozole, we can 2.5 to 5 mg for 5 consecutive days, starting from day 2 or day 3 of cycle.
Anybody who would like to differ in here and would like to do something else for the women, or you think that moving on from clomiphene to letrozole or something is the...
Add metformin.
Any other panelists would like to comment in here? Or our experts, and what is your common practice if you would encounter a scenario here? How frequently do you actually use a dose of 150 mg clomiphene in your practice? Although it is the maximal dose, maximal approved dose of clomiphene that is there, but women who do not respond to 100 mg, the fear of anti-estrogenic effect of 150.
Yes.
I personally do not prefer to use 150 mg in my practice, and I'm an early adder of gonadotropin. But what do our experts say in here? That would they move to letrozole or add a gonadotropin or what else?
Here I would like to add some basic physiology. Now the thing is that we have to see about the antral follicle count on day 2. Now, even if the antral follicle count you're not finding adequate, whatever amount of clomiphene citrate you increase, it won't going to respond, because it is these follicles which will respond. So basically it is the dose you have to decide based on these counts, and just increasing it won't lead. So there are so many papers now focusing on this, that even if you give this gonadotropins, so what should be the maximum dose? Like previously, I must say 20 years back in 2001 or 2, we used to go up to 600 international units. But nowadays, anybody is hardly using these type of protocols. So this is what I would like to add, that antral follicle count is very, very important. So just as Madam has rightly pointed out that you can see about this AMH, antral follicle count, and then you can have this dose. And even those who are going to respond will respond to 50 or 100 also. This is my personal experience.
So I think what we know from here is there are certain set of women in PCO who would not respond to oral ovulogens. And I would like to know from Dr. Madhuprita, what exactly are these kind of women? And apart from what oral ovulogens are offering, what extra can be done? So instead of focusing just on the ovulation part, is there something in terms of adjuvants that we can give to this woman, or move on to some second line who are not responding to oral ovulogens? Dr. Madhuprita, are you there? Dr. Madhuprita, I can't hear you. Any other panelists who would like to answer in here? Dr. Munmur, would you like to take this up?
Yeah, so if the patient is not responding to oral overvisions, there are two options. Either we go to gonadotropins or we consider her for laparoscopic ovarian diathermy. So we need to take a consent, a proper counseling of the patient and discuss with her the options and accordingly decide our next step.
What about the adjuvants? What is the role of adjuvants in resistant PCO women?
Metformin, yes, as we have all discussed, the insulin sensitizer, it is really helpful in obese PCOS. In lean PCOS, dexamethasone does come to a rescue to a certain extent. And minoxidil is to an extent, but not much, I think.
So yes, a lot of our women in our first counseling session, probably after the evaluation of OGTT, may have already been taking metformin or minoxidil or some other form of insulin sensitizers, and these are the women that we are choosing to undergo ovulation induction. Metformin as an isolated drug has also been used, but then there are specific indications for started metformin. So Dr.
Excuse me, ma'am, am I audible now?
Sorry, that's Dr. Madhu's.
Yeah, Madhuprita.
Yes, Dr. Madhuprita, you're audible, please.
Yeah, yes. I was sorry for that. Ma'am, the patient is not responding to oral ovulations. I think we can opt for second line of drug therapy also. We can go for gonadotropins. And before shifting to gonadotropin, we can add adjuvants also, like metformin can be added in CC resistant cases.
Dr.
And
Madhuprita, what do you think are indications for adding metformin? Who are the category of women that you would like to add metformin to? And what is the dose and what is the duration? When do you stop, etc.?
In CC resistant cases, there are specific criteria to add metformin. First is CC resistant cases. And second, when we can also give to overweight, this patient whose BMI is more than 25. And if we have already put them on lifestyle management and patient is not responding, then also we can add metformin to them. And the clear cases of PCOS who has impaired glucose tolerance test, in those cases also we can add metformin. And if we are going for IVF or in cases we want to prevent OHSS, then also metformin can be added. So the criteria, but very important that the metformin we are adding with years of experience, but there are side effects with the metformin. So starting dose should be like, once we should give OD for 7 days, like once in a day, 500 milligram, and then the metformin should be step up to TID dose gradually, so that we don't face the side effect as such.
I would like to know from our experts, Dr. Bharti ma'am and Dr. Preeti, that when do you stop metformin? Once this woman get pregnant who was on ovulation induction and she was on metformin with lifestyle modification, in pregnancy, what is your take on metformin in pregnancy, especially in the first trimester?
It has to be continued for first trimester to reduce the abortion rates. That is what the literature suggests.
So we need to see actually how metformin was started. If the woman actually felt was already in the pre-diabetic range and there was an abnormal OGTT, probably shifting over to insulin would be better, seeing her current glucose status. But otherwise, for all other reasons where we have added metformin for clomiphene resistance or letrozole resistance, probably it should be continued till the first trimester, as Dr. Preeti rightly said. What is the role of myoinositol, Dr. Munmu? We have discussed that we have been using it in lean PCOS or women who are not
lean PCOS. Exactly. And it is basically in patients with insulin resistance. So myoinositol is a secondary messenger, and in insulin resistance, we see decreased myoinositol. So it is added because it's a secondary messenger and it sensitizes increases the action of insulin. So it decreases the hyperandrogenism. It makes the cell sensitive to insulin. It also decreases hepatic gluconeogenesis.
Dr.
So in this way,
Mona,
minoxidil is
inositol, we have two of them, myoinositol and decainositol.
yeah.
Do you think a
So the
combination is necessary, or only myoinositol should be used, or there is something that you would like to enlighten us about? A combination.
it is combination in the ratio of 40:1 is usually recommended because myoinositol is the more active isomer of ionositol. And this is what it gets converted to dechloreinositol also. So it is usually given in the dose of 40:1. And the dosage is 4 grams. So it's basically 2 grams BD.
So, Dr. Rashmi, this woman was given clomiphene and letrozole, and as an adjuvant metformin was given, and she did not ovulate. What we move on to the next line, as we have discussed, that's gonadotropin. So, what gonadotropin, what dosage, and what protocol would you like to follow for her?
Ma'am, in this case, we can, if we are heading towards the gonadotropins, then we can opt for step-up protocol. We can start with the low-dose gonadotropins. Option either, if you'll ask whether to start with recombinant FSH or HMG. So I'll say the pregnancy-wise, there is no significant difference in whether we are using recombinant FSH or HMG. So we can use either of these. Of course, the bioactivity of the REC-FSH and the overall dosing of the REC-FSH is low. So, and the patient is affording. So I'll go with the REC-FSH. Otherwise, HMG can also be used. So we can start with the, depending on the BMI and AMH of the patient, we can start with the low dose. And then if the patient, we can do monitoring after 7 days. If she is not responding, we can increase the dose by 50%. Or if she is responding, we can continue the dose.
Dr. Preeti Upadhyay, herein I would like to know, is there any other gonadotropin protocol that you would like or you can use, or from your practice that you can enlighten us upon, apart from chronic low-dose step-up protocol that Dr. Rashmi has already mentioned?
Chronic low-dose protocol, we can also use it started in the gonadotropin. It starts from the day 3 with the dose of 37.5 IU of REC-FSH, and
that's what Dr. Rashmi said. But any other gonadotropin protocol that you've been using?
Yes, we can so many other protocols we can use along. We can combine the letrozole with the gonadotropins, the intermittent therapy, on the day 3 alternate day therapy. On day 3, day 5, and day 7, we can use the gonadotropin, and we can see for the follicular growth on folliculometry. If a follicle is growing properly and gaining the size of 14 mm, we can continue with the same REC-FSH, or we can use the sequential regime like day 3 to day 7 letrozole, and after day 7 we can use that REC-FSH, so that it is a mild stimulation protocol. The doses and duration, both of gonadotropins, it will be less, so there is less chances of OHSs in these cases.
So depending upon the woman that we are dealing with, her financial background, her ease of follow-up, affordability and everything, we need to individualize this stimulation protocol for her. And this woman who's very frustrated after so many cycles, we have to tell her that this time to pregnancy is going to be a little longer for her. And we need to find the right tailored protocol for her, and the cost that is involved in both the stimulation that we are talking. Combination one is definitely going to be much cheaper as compared to a pure gonadotropin cycle. And we have had ample data that suggests both of them have yielded good response in either of the cases. So we talked about low dose step-up regime, and as rightly said, we start with a very low dose in 37.5 or 50 and escalate every week depending upon the follicle size and the E2 levels. And once we have a follicular response, the trigger is given. But are there any other stimulation protocols apart from this that you've heard of? Dr. Shilpa, would you like to talk about any newer protocols with letrozole or?
Ma'am, as we can start the letrozole from the day 2 of the cycle up to day 6, and we can add on day 3 HMG or FHS up to unit 75 international unit, and we should scan on day 7 also. Previously, we should ideally scan on day 2 and day 7, and we can add on HMG or FHS 75 international unit on day 3 and day 8 also. And then we can follow the follicle growth.
Yes, that's there, but there were certain.
We can also
Letrozole, we can
step up letrozole protocol, like day 2 single dose, then day 3 and till 10 milligram we can go from starting from 2.5, and one more is extended letrozole protocol can also be.
So what is your personal experience with such protocols? Have you seen women with high AMH and high FC and hyperandrogenism responding?
Yeah, I frequently use step up letrozole protocol, and it is working for me. So step up with letrozole is also a good to go about.
And similarly, we have extended letrozole therapy, and the letrozole is given for a longer duration and it is shown to give
good results.
Prominent follicle. So gonadotropins, we discussed that they have to be individualized. They are the second line of treatment. And because of the cost and availability, expertise required for ovulation induction, degree of intensive ultrasound monitoring, the feasibility becomes less often in a lot of patients. Dr. Shilpa, who are all the candidates that are candidates for actually laparoscopic ovarian drilling? Laparoscopic ovarian drilling has gone into disrepute because of the rise of use of gonadotropins. So who do you still think are candidates for laparoscopic ovarian drilling in current era?
Primary option for ovulation induction. It should be reserved for very selective patients like and ovulatory women who fail to respond to oral ovulogents. And second, more important, patients, as Bharti ma'am told us earlier, lean PCOS with the raised LH, as those fail to respond with aromatase inhibitors also. So it should be used judiciously and by the experienced surgeons only in selective cases.
I would just like to put up a scenario. There is a woman who is 28, 29 years of age. AMH is 8, or you can say AMH is 10. Then there is another woman of 38, 39 years of age with AMH of 10. So where will you consider that there is role of laparoscopic ovarian drilling? And if there is some role, what all precautions you would like to take while drilling? Any of the panelists, if they wish to answer, or else the questions will go to our experts and they have to throw light on this.
In young age woman, that 29-year-old with AMH 10, we would like to do the LOD. We will prefer, as the younger the woman, that more chances of OHS, higher the AMH. But in the old age, we will not, we will try to conserve our ovarian reserve. In that case, we will not prefer the LOD for the first choice, or as there may be the
Dr. Preeti, the old lady also have a very high ovarian reserve. She is having AMH also of 10.
Can I just start?
Yes, ma'am.
I will not do laparoscopic ovarian drilling in both the patients. Number one, her AMH level is more than 10. Now, what happens if you do drilling? We are now going for rule of 4. That means 4 punctures, 40 day, 40 current, and kind of that. So now, when her AMH is 10 and more, whatever you've been saying, naturally her follicle would be more than 25, or either of the side maybe 50 or kind of that. In that follicles, if you just puncture 4, how much androgen levels you are going to bring down is a question. So it is वो जो बूंद में समुद्र में बूंद के बराबर है वो, उसको कोई फायदा ही नहीं है. That was a very beautiful article. It had come, and that actually opened my eyes that time. And it was surprisingly, when I had that title of that topic was that article was more than like high AMH, no results with the laparoscopic ovarian drilling. I said we were all the time thinking that more the AMH would be more better for laparoscopic ovarian. And then I went through the details of that article, and we realized that it definitely, when the patient is crossing approximately 8 to 9 to 10 AMH, don't drill. It is of no use, because categorically, if you see these patients drilling and later on you see they don't ovulate, so it is of no use for them. And if you look at the age of the patient, as you said, AMH, whatever it may be, age is age. So they will accelerated decline they will have after 38. Right now they have AMH 10, they have many follicles, but those follicles could be empty follicles and they will drastically go down. So definitely age will make a lot of difference in deciding the laparoscopic ovarian drilling. This is what I practice in my own clinical scenarios. So you tell me now.
Yeah.
So what was your
Ma'am,
take
you are
on
very
those
right.
cases?
Young patients, even if they have high AMH, until or unless they are into rush, laparoscopic ovarian drilling has no role, because we also don't know that for how long they will be infertile. So we want their results to be preserved for a longer period of time. So there comes the
Absolutely right.
role of patients' diet and lifestyle management. In old age patients, where we know that PCO along with aging both are contributing to the poor quality oocyte, but alone laparoscopic ovarian drilling will have no role. In older cases where we see that we have a limited lifetime of reproductive years, anyhow she will have aging eggs, and aged eggs themselves are a poor prognostic factors. There are few articles, and we ourselves have observed in our experience, that in such cases, if we do drilling, but drilling has to be done in stroma, not in the follicles. We have to be very precise that it should be stromal drilling, anti-mesenteric, so that we are not compromising the blood circulation. Then maybe there is some role, but yes, medicines should be tried first. If we feel that there are no options left and patient has been resistant to medicine, in older patients, we may consider, where the reserves are very high, we may consider drilling, but no role of drilling just seeing the pearly white bulky ovaries on ultrasound or on laparoscopy, where we have seen that women are coming with diminished or approximately no ovarian reserves after drilling. And it's better not to do, still less worse, do less. Worst is to do the overzealous drilling. So we have to be very careful in selecting our cases for laparoscopic ovarian drilling. And madam, you were very right that drilling has been a very fascinating things for the surgeon, especially for the laparoscopic surgeons. But we as reproductive medicine expert have to be very wise to decide where we should go for drilling. It has very limited role, and madam has almost pointed out all the limitations and pitfalls of the LOD.
I would just add a few points. Please, Bharti madam, please carry on.
Go on, Preeti.
Madam, now it is 22 years of my practice. In initial years, when I used to do drilling, so what I noticed, these all things that we have to go deep into stroma, and then the ovary used to start bleeding, and then bipolar quaterization and all those type of things. So after few years, I learned that maybe the reproductive outcome is not improving, but at the same time, with all these sort of things, we are leading to premature ovarian failure in these patients.
Yes.
So a very, very big no to all these things, because however precise you may be, but I never understood this fact that without puncturing the follicle, how can you go to stroma?
No, that is what, Preeti, you are absolutely right. And I wanted to just discuss this with Neeraj also.
I never understood
Whenever
this
you have
point,
been,
and still I see videos on YouTube and all the things.
No. See, very importantly, you tell me one very important thing here. I want to actually discuss with you all. I don't know whether I'm right or wrong, but then see, follicles are approximately 2 to 9 millimeters, right? All the follicles are 2 to 9 millimeter. Now, if you see ovarian drilling needle, it has got only 4 millimeter. 4 millimeter. Have you anybody precisely measured that? If you not, please measure that. It is 4 millimeter. It's a 4 millimeter, 4 punctures, 40 watt.
From
What
here
was
came the
being
rule of
short, and that rule of 4 was in. Now, 4 millimeter needle will not go to the stroma at all. And the moment you reach the stroma, it is going to be very difficult. So why then we have been puncturing the follicle? But because whenever you're drilling, it is a unipolar current. Unipolar current. It has a spread minimum 4 millimeter around it. So whenever you're puncturing in the center, it automatically goes till the stroma. You don't have to prick the stroma. You don't, because the unipolar current is going to spread, and that's why it has to be only 40 watt, only for 4 seconds, and only 4 millimeter. And that was actually rule of 4. But still, it doesn't apply to all PCO patient, because if a patient has a many follicles, what that 4 punctures are going to do? Nothing. So you don't have to reach to the stroma with all your PCO needle completely. It doesn't require that. So this is what my way of looking at the PCO procedure as such, drilling procedure as such. Neeraj, you.
Yeah, ma'am, very right. But this.
You're not audible. Hello? You're not out.
Unmute first.
Hello? You're not audible.
Yeah, sorry. You're very right, ma'am. This is a very controversial topic. So if we keep on discussing, it will go on and on and on, leading us nowhere. But you have concluded it very rightly that puncture has to be very precisely. It is not possible that we can do a precise stromal puncture. But I disagree to one point that puncturing the follicle will have no results. It's just like satisfying ourselves that we are doing it. But there have been many papers which are advocating what you are saying, and obviously you have much more experience than us, so we'll go with your words only. What I do in my practice, that I avoid puncturing the follicles. In between the follicles, there is a whitish area which we assume that will give us the desired result, and try to puncture those areas, assuming that this will give us maximum benefit of LOD, whatever.
No. But this is what the follicles which have enlarged you are seeing. But the entire periphery is containing only those
follicles. It will give us.
No, she has a point. Neeraj has a point, because what she's saying, this I had never thought about. Like, she's saying in between the follicle you puncture. Oh, that I haven't done. Actually, I'm not a very big fan of drilling, no, so I've not done only. Last many years I've done.
I learned this because when I was in Cleveland, I worked with the laparoscopic surgeon who was very fond of LOD, and every time we used to have a big discussion to do, not to do. So I don't know for what reason he was having very good results with LOD. So this technique,
probably I agree. I agree, because I fully agree. I think we should see, because this concept I never thought of also. In between the follicles, probably we may try and see a few of the patients whether it is. You're right, because I was thinking that follicle mein jao and phir wahan tak kaise. But you have a right. Take home. Good. Let's see. We'll come out. I'll talk to you later if I see that later.
Dr. Rhythm? Are we allowed to continue further, or
that's also one thing.
Already 9 o'clock. So what the experts have to say on this? Are we allowed, or Madam can conclude?
I think you have only one side. No, Rhythm has completed her. You can quickly go fast.
No. It's Madam Rhythm is only taking the charge. So she
Ma'am, please take over. Neeraj ma'am.
I cannot see the slide. I think that I am very bad in technology. So you are continuing sharing the slides now. So you please continue.
I think you continue, because this is very interesting discussion. Maybe another 5 minutes and 5 to
7 minutes we wind up. It's a short panel. So we have essentially seen the ovulation induction protocols. We moved on from oral ovulogens to resistant to gonadotropin to LOD. Now here is one particular scenario. This woman was given a combination of letrozole and a gonadotropin. This woman was given a combination of clomiphene and gonadotropin given on 3 days. But we found that when the dominant follicle was 18.8 on the right side, her endometrial thickness was 4.8. So Dr. Madhuprita, I would like to know from you that how do you proceed in such women, that you did a follicle scan and you saw this, and what do you advise and how do you improve the thickness here in this cycle or henceforth in other cycles?
Ma'am, in this case, we are looking at the endometrium, which is not at par with the follicle, right? Ovary is having a dominant follicle of 18 millimeters, but endometrium is just 4.8. But it's on day 16. I think it's already too late because while doing the folliculometry, by the time we are going to day 16, we should have realized that endometrium is not growing at par with the follicle. So if I would have detected it earlier, maybe I would have added something to improve the vascularity, like sildenafil or aspirin could have been added. Estradiol valerate, I would say its role is like controversial. It may improve the endometrial thickness, but the pregnancy rates are not as such. They remain same. They are not at such improved. At this point of time, I would in this cycle, I don't think I would be able to do much about it. But moving on to the next cycle, I would first like to know why it was so thin. Is it something else, like is it a case of chronic endometritis am I dealing, or there may be some tuberculosis or some Asherman or something else which is causing such a thin endometrium, or maybe drug induced, which drug we are using for the stimulation. So accordingly, I would like to know the cause, and maybe the next cycle it may be rescued, but this cycle on day 16, I think it's too late. And maybe if she is on time coitus, so I would maybe start estradiol, but I don't think it will have some benefit over the pregnancy rates. So
okay, had it been just a pure oral ovulation cycle, Dr. Madhuprita, anything else that you would like to add on here? If it was not a gonadotropin cycle, just an oral ovulation cycle.
Yeah, if it would have been because of like clomiphene citrate, so next time letrozole would I would have like to add letrozole. So in the and it should be started early, like day 2. Clomiphene should not be started very late, like day 5. Then it may have endometrial side effect. Otherwise, if I see it is because of drug, then I would go to letrozole or gonadotropins.
Okay, so a couple of things, sir. First, you said the cycle, it is a delayed egg formation. We expect this very commonly, that the dominant follicle develops around day 16 to day 20 of the cycle. So even if the follicle development is on a later date, we should give an optimal chance of pregnancy to that woman. Secondly, if it was a purely oral ovulation cycle, we usually see a rupture at around a size of 24 to 26 mm in clomiphene and in letrozole. So we still have 2-3 days. And we know a normal going endometrium would have grown by a rate of 1 mm per day and a follicle at 2 mm per day. So probably this 4.8 that we are seeing on day 16, on day 19 could be more than 7 mm, and she would still have a chance in this cycle itself. Thirdly, as you spoke of other things, adjuvants can be added. Yes, they give good results, sildenafil, aspirin, but that's an individual choice and evidence is lacking. If we see in IUI or natural conception cycles or only in PCO. But regarding estrogen, you said it does improve the endometrial thickness, but we have to see that if the effect is due to repeated clomiphene citrate cycle, because it is the anti-estrogenic effect of clomiphene citrate, probably even adding an estradiol would not lead to any kind of improvement in the thickness, because the receptors are already blocked and there would be no place for the estrogen to act on to improve the thickness. So but a combination cycle, yes, a gonadotropin and oral ovulation cycle, this particular cycle may lead to a rupture in the subsequent day, and we would have a langic endometrium, and that can be evaluated in the subsequent cycle. And herein also comes the role of tamoxifen, because tamoxifen, I don't know, what do our experts say, and what do Dr. Neeraj say about use of tamoxifen in such women?
Dr. Rhythm, I'm not a big fan, in fact, not at all a fan of tamoxifen usage. Here, definitely, I would like to consider her menstrual history. If she has a prolonged cycle, say of 40 days, 50 days, 60 days, we all know that a follicle anytime between 14 to 24 millimeter can give us a mature oocyte. So if she has a prolonged cycle, 18 mm, maybe we are just too early to predict. If follicle thereafter is growing, at a times we have seen endometrium growing at a pace of 2 to 3 millimeter per day, on an average of 1 to 2 millimeter per day. So just let us observe for another 2, 3, or 4 days. Or else, if there is any such thing, we all know that PCO is most of the time associated with endometrial hyperplasia. So from next time onwards, instead of changing or switching over to any stimulation protocol, if I'm consistently seeing that in spite of all the measures, follicle is getting rupture on time, but the endometrium is not growing appropriately, I would focus more why the endometrium is not growing. Is there any endometrial pathology that we are missing out? We would like to do endometrial hysteroscopy, and also would like to see any, now that nowadays tests are also available to rule out chronic endometritis. Most of the time, if there is recurrent vaginitis or cervicitis, that also negatively impact the endometrial growth. So we have to rule out all those things first, and then if we are sure that there is no endometrial pathology, I usually prefer going for letrozole, no gonadotrophins, because gonadotrophin will give early follicular maturation. I just want to wait for a longer period of time. Doesn't matter if the follicle is taking long. But along with letrozole, I would like to try the adjuvants, like seen good results with sildenafil, vaginal sildenafil, and argiol. Definitely no role of estradiol, especially if it is given before 15 mm the follicle has reached to the size. And tamoxifen, Dr. Rhythm, whatever literature has said, I have only that limited knowledge. I have not used, and I will not be using tamoxifen in any such cases because of my certain reservations in mind. So if you want to throw some light on it, or Bharti madam has to conclude on it.
I'm absolutely with you. I don't use tamoxifen. I'm not a very great, in fact, I don't use at all. Tamoxifen is no, I don't know why, but that concept wise, tamoxifen doesn't fit into my mind. So tamoxifen is no, and I think you very, very rightly said. So no need of adding absolutely precise thought process. And I think this is the way, even rhythm, it is correct, because 18 millimeter follicle, still PCO patient, longer menstrual cycle, they have a longer follicular phase. So we may have to wait. Sometimes it just jumps up. Just see whether the pattern of that endometrium is how, even if it is 4.8 also, if it is a hyperestrogenic, thick, then that is of no use, even if you wait also. But if it is a trilaminar, definitely it opens up. So
usually it is trilaminar lagging endometrium that just flares up after 1 or 2 days before we can see a rupture. In fact, sometimes after trigger, they show that expanded trilaminar response. So
here I would go for a color Doppler, Doppler indices, blood flow indices of that follicle. If my follicle is ready for rupture or not, I will look at the peak systolic velocity. If it is less than 5 or 5 to 7, it has still time. So I will wait. And her resistance index, if it is less than 0.5, I will just, if it is 0.5 and more than PSV 10, then that means the follicle is ready. Then it's of no use, whatever you do for that endometrium. But if it is waiting, like if it is still time, PSV is low, RI is more, these patients still have time to go ahead. So I will add in my things as a color Doppler indices for these patients to understand whether to drop this cycle or to continue. And that will help actually when you give trigger also. That is what your next question is.
Yes. So Dr. Monman, when would you like to give the trigger to such patients?
Yeah, so as ma'am rightly said, so when to give trigger, so we have to see the follicular size. When it has attained the size of more than 18 to 20, the endometrial thickness, somewhere around more than 8, I expect. And yes, as rightly pointed out, the Doppler values, the perifollicular flow should be more than 3/4. The RI should be somewhere between 0.4 to 0.8, and the PSV more than 10 of the perifollicular flow. If these are the Doppler findings, and along with that, sometimes we see a small sonolucent halo also in the follicle. A small cumulus can also be seen. these are the little signs of ovulation, that the follicle is ready for ovulation. So then we can plan our trigger.
Another thing, Dr. Monman, please clarify here also on the type M dose, because there's a confusion with some people about 5,000, 10,000, which is better if
So
you have.
I think ideal dose would be Hcg 10,000. Hcg 10,000 is the best trigger in a normal cycle. Recombinant 250 Hcg is expensive. So in a day-to-day practice, if you're going for a simple ovulation induction with the time intercourse, 10,000 Hcg should be the ideal dose.
Well, anybody who would have any difference of opinion on this, because I don't know, how is everybody using 10,000 Hcg as a treatment?
5,000, 10,000 has actually, it's a dose dependent study has been proved that doesn't make any difference, 5,000 or 10,000. But in Indian scenario, some HCGs, they are urinary, batch to batch variability is there. And people start tending, abhi 5 mein nahi aaya, to next time 10 mein dete. So kind of that. Otherwise, it doesn't make any difference. 5,000 or 10,000, only if the patient's BMI is very high. If the patient is little overweight or obese, then 10,000. Otherwise, 5,000 is fine. Urinary HCG versus recombinant HCG, no difference actually, but urinaries are always batch to batch variability. So if patient affords, probably recombinant HCG is the best way to go ahead. This is from our IVF experience, because whenever you do urinary and you may get empty follicle syndrome and like that, this patient doesn't reach only the HCG. So recombinant is always, we are sure about it. So maybe if the patient is affordable, definitely give. Or if it is not happening this time in IUI, next time change the brand and see whether the HCG is good or not, urinary especially.
So, Dr. Rashmi, two things that we are worried about is multiple pregnancy and OHSS. So, what do you think are criteria when you would cancel a cycle of ovulation, induction, or other ovarian stimulation in a PCO woman?
Yeah, ma'am. In when we are fearing the in order to having a multiple pregnancy, to avoid multiple pregnancy, whenever we are facing when number of follicles are more than 3, reaching up to dominant size of approx 14 mm, so we just cancel the cycle. And if you are following the E2 level, so if the E2 level is more than 1,000 to 1,500 gram per ml, then also we tends to cancel the cycle.
Rashmi, would you straight away like to cancel the cycle, or you would like to help patients some or the other way so that the cycle is not cancelled and also the multiple risk of multiple pregnancy or OHS can be prevented?
Ma'am, it depends on the patient. Like we can also if the follicles are more, like we can also if the patient is willing and it is more than, like we can convert it into IVF cycle also. So
very right, one of the options. And if she's not willing for IVF, then do you think is there any other option available? Any of our panelists, if they wish to add?
Yeah, some people, they have to also tried like aspirating the extra follicles. Like if we are seeing 4, 5, so aspiration of other follicle and leaving behind 1 or 2 follicles. So that has also been tried.
Is there any role of ghosting here? Any role of adding antag?
Antag, yeah, ma'am, antag can be added.
I think so.
But no. But the pregnancy rate would be completely different. Like you're worried about hyperstimulation. Why you are adding antagonist is you're worried about the hyperstimulation. Now, Dr. Neeraj is saying, can we rescue this? Means, can we still have a pregnancy in these patients rather than cancelling the things?
Instead of cancelling,
cancelling will definitely have no pregnancy. फिर तुम बंद करो या you give antagonist, doesn't make any difference. Both the things are similar. What else you can do? Like still you rescue this cycle. This is what
Posting can be done.
Wants.
Posting, I don't think.
Posting can be tried. We can delay, stop the medications for 1 or 2 days, and we can see for the estrogen level, it becomes flattened or plateau or decreases, then we can give the trigger and we can try for the.
Yeah, correct, Preeti. But this is only now costing studies have been shown through that 24 hours only. If you coast
Yes, 24
hours, then it is okay. If it crosses 48 hours, that has a detrimental effect because it
Results are very
starts
different.
apoptosis of the granulosa cells. So it is of no use. One day you can still have the rescue cycle, but probably if the 3 or more follicles are there and more than 16 millimeter, only in those patients, because dominance has already occurred. Now, if the dominance has occurred, sometimes one of the follicle may have a very good potential growth of the granulosa cells growth. So you can see by like 1 or 2 days and then maybe take a call. But it is completely at that time the decision will be, because we don't see the granular cells, we don't know how it is going to react. But
the idea of ovulation induction and ovarian stimulation has always been to simulate a natural cycle. Whether we have to keep it very simple, we have to keep it as close to as physiologically it is possible. Adding an antagonist or coasting is more so in IVF cycles when we are dealing with timed intercourse, ovulation induction, looking for only one dominant follicle, and by chance we have 2-3 follicles. Herein, we should not try to complicate the cycle, because adding an antagonist also, even an IUI cycle, has yielded only 1 in 25 better outcomes. Rest 24 goes waste. It just adds on to the cost. So for a woman who's already spending on gonadotropins, adding on to the cost of antagonist probably may or may not help. And as rightly ma'am said, the results are still not known. But yes, at the same time, we should also keep in mind the background fecundity of this woman that is coming to you. Somebody who has been ovulating every time, but not getting pregnant, whether it was on clomiphene or on letrozole, and this time you have made 3 follicles for her. Probably you should give her a chance to try, because as it is in her, the natural fecundity is on a lower side. But yes, this all goes with a underlying counseling of multiple pregnancy and the baseline OHSS risk that this woman already has. So with this, I think I would like to ask something to our experts. Is there a role of GnRH agonist trigger in a woman with 3 dominant follicles?
yes, it is. You can give trigger, but you have to rescue the luteal phase support for her. Somehow, both the ways, it is double-edged sword. So even if you give agonist, the follicles would come rupture. But definitely her hyperstimulation possibility would be very, very low. So give her GnRH agonist trigger. And maybe in case if you don't want multiple pregnancies, I would ask the patient not to have even timely intercourse also. But as you said correctly, I agree to this. This is a take home for me also, because this aspect I did not think about. Like, they have a low fecundity. They are, in spite of so many ovulations, they are not been having a conception. So in that scenario, if one follicle has good eggs, another may not have another good egg, but one of them may be going ahead and may give her a pregnancy. So we should take a chance, but with proper counseling of multiple pregnancy. But she will not go into hyperstimulation with these 3 only follicles. Usually no. And you have so many things in our hand to avoid that hyperstimulation. So I think she can go ahead and we can give a chance to her rather than totally cancelling. But don't do IUIs in these patients. This is what I felt. IUIs mat karo. You just follow them. So this is what my way of looking at it.
One more question, madam. If pregnancy will occur, then pregnancy itself is a
OHSS? I know, hyperstimulation. Na? So that's what she said. Na? See, there are 2. Secondary hyperstimulation is another thing, which you are correctly said. In case also, if she becomes pregnant also, you achieve pregnancy, but she'll end up into
If they become pregnant, they tolerate OHS very well.
Yeah, but what I look at it, if there are 3 follicles, look at the behind follicles, how many? If there are only 3 follicles and there are no other follicles, like they all are 2 to 4 millimeters, then that's fine. They will not go into that. But if suppose all other follicles are also budging, like this is 18-20 millimeter, but other are 14 millimeter, 16 millimeter, then later on. And as you very correctly said, Preeti, we will land up with secondary hyperstimulation. Agree. Double-edged sword. It is.
So, Dr. Preeti, the strategies to prevent OHSS we have broadly discussed everywhere, how to go about it. Just summarize it for us. And with this, we'll have the last question now. I think it's.
First, we have to identify the high-risk cases, as I will be talking very shortly. That the lean thin PCOS, the low BMI, the young patients, previous history of OHSS, stromal velocity is more than 10 centimeter per square, and ovarian volume more than 10 cc. And as the Prakriti already discussed, that at the time of stimulation, if the serum estradiol, in case of IVF, it is more than 4,000 picogram per ml, and that in case of IUI, 1,700 picogram per ml. And to prevent the primary prevention, the secondary prevention. The primary prevention is the use of antagonist protocol. And first, to optimize the dose of gonadotropin, it should be categorized on the basis of age, AMH, AFC, and individualize the protocol. And to start the initial dose of gonadotropin should be properly decided. And ovarian drilling may play a role in case of lean thin PCO. They are as the Madam Bharti Madam already said. And by using the adjuvant like metformin, it should be given in the dose of 500 TDS for at least 6 to 12 weeks prior to IVF. And avoid the use of luteal SCG in the luteal phase. And in secondary prevention, as already we have stimulated and so many follicles are developing, in that case, we have to avoid the SCG trigger. In case of antagonist cycle, we should give an agonist trigger. We can use the LH, recombinant LH as a trigger, but it's not feasible because very short half-life and so many doses are required when very costly also. And as if there is so many other adjuvant therapies are also there, that use of human albumin, use of haze, and that calcium gluconate, and we can do that dopamine, cabergoline, we can continue at the time of SCG trigger to for 8 days, 0.5 milligram daily. And what else? We can continue the antagonist for 5 more days. And these all the regime. And the definite is cancellation of the cycle, and tell the abstinence, tell to follow the abstinence. That's very important.
Only one thing, madam, I would like to add, that even the cancellation of the cycle may still carry on the risk of ovarian hyperstimulation. Many times you don't do, still these patients, they go into ovarian hyperstimulation. So it is the basic strategy should start from day 2, what protocol you are using on what type of patients, and just prevent it.
Just prevent it.
Thank you. Thanks all of our panelists and experts for giving their valuable insights. And with all such healthy and challenging discussions, each one of us grow every day and become expert in our own field. So I thank you all from core of my heart for sparing your valuable time and giving sharing your expertise, your experience with all of us.
Excellent panel it was. All excellent panel, good moderators, very precise thought process. I think Prakriti, you had been done a wonderful job. I think we should give all applause to Prakriti. She has done the wonderful. She made me to do these all things, and we will be always thankful to you, PCOS SIG group of IVA, this IFS. And thank you very much. And wonderful panel. I'll tell you, all panelists, all moderator, extremely well and clean thought process. This is what I really liked. Thank you very much.
Thank you so much, ma'am.
Thank you.
Thank you, ma'am. Thank you all.
Thank you so much, Dr. Bharti ma'am, Dr. Menon sir, Dr. Ridham ma'am, and our experts, speakers, moderators, chairpersons, and all the panelists. Thank you so
You are
much.
very quick, Shweta. Very
Thank
nice.
you.
She did very
Thank
well.
you,
Good job.
ma'am.
Chalo, okay, thank you.
Thank you so much.
Thank you.
Good
Okay.
night. Good night.
Thank you so much.
Thank you, ma'am. Bye-bye.